Joint Secretary, to give the welcome address.
A very good evening to all of you. We've thus far had a very invigorating session of discussions on the etiology and epidemiology of clubfoot, as well as a very detailed session by regarding the management of clubfoot by Dr. Matthew Verghese, who is the honorary medical director of Cure India Foundation. And now we enter the second session of the International Clubfoot Conference. My duty here is to welcome the initial dignitaries who are going to be with us through this session. Let me first of all welcome the Honorable Health and Family Welfare Minister of Kerala, Srimati Veena George. Welcome, ma'am, to the second session of the conference. I would also like Vikas Sheila IAS, who is the Additional Secretary and Mission Director of the National Health Mission at the Ministry of Health and Family Welfare, Government of India. I welcome both dignitaries to this session, and we hope that what we are going to go through in the second half is going to be even more interesting than the first one. In addition to the two dignitaries who are going to talk to us initially, we also have a discussion on the Kerala Clubfoot program by Dr. Rajan Khobragade IAS, the Principal Secretary of the Health and Family Welfare Department, Government of Kerala. And also joining him is Dr. Manoj, orthopedic consultant at the Clubfoot Clinic in Taluk Hospital, Trikaripur. I welcome both of them. And following this at 5 o'clock, we also have the Clubfoot non-invasive management discussion. Dr. Santosh George, Director of Cure India, will lead the discussion on civil society and government partnership, where he will be talking to us about elimination of disability from clubfoot, the Cure India model. We'll also have Dr. Shafiq Pirani, one of the stalwarts in this field, who will tell us more about the Pirani score and how it helps him treat clubfoot more efficiently. We also have Dr. Matthew Verghese, who already spoke to us in the previous session, who will now be telling us about clubfoot management, the public health model. And then we will go on to the plenary talk on clubfoot management by Ms. Rosalind Owen, who is the Executive Director of the Global Clubfoot Initiative, London, UK. Following this, we will have at 6:30 the roundtable discussion on clubfoot management and the way forward. Now, I request the Honorable Minister for Health and Family Welfare, Government of Kerala, Srimati Veena George, to address the session. Thank you.
Everyone, distinguished guests, Sri Vikas Sheila IAS, Dr. Pirani, and my dear colleagues and dear friends. I'm so happy that this national conference is turning out to be a very fruitful one, as we have all expected. Clubfoot-free Kerala is our aim and vision. And I learned that this is one of the unique initiatives in the entire world. Our Honorable Chief Minister, Shri Pinarayi Vijayan, has inaugurated the international conference today morning. Ensuring good quality of life to all, to everyone, is our aim. Reducing the discomfort and problems due to disabilities, or eliminating disabilities if possible, is what we are trying to do. So far as this clubfoot is concerned, we are taking up this project to train doctors and to build up awareness among parents, because parents, they are very worried whether their child, he or she can have a normal life, a usual life like other children. So with early intervention, proper intervention, it's learned that clubfoot can be totally corrected without any surgery. I'm happy that many distinguished guests, many experts in the field from all over the world, they're attending this conference. I once again congratulate my colleagues for organizing such a wonderful conference today. And the afternoon session, it will be a more interactive one. And again, I'm wishing all success and my good wishes to all. Thank you very much.
Thank you, ma'am. I invite Sri Vigashil IAS, Additional Secretary and Mission Director, NHM, Ministry of Health and Family Welfare, Government of India, for the keynote address.
Thank you. Am I audible? Can you confirm, please?
Yes, you are.
Yes, sir.
Thank you. Honorable Minister for Health and Family Welfare, Government of Kerala, Srimati Veena George ji, senior colleagues from the Department of Health and Family Welfare in Government of Kerala, various partners, experts, and all the participants of this seminar. At the outset, I express my thanks to the Government of Kerala for inviting me to be a part of this workshop. I'm sure that during the course of the day, a whole lot of discussions would have taken place, and going forward too, various aspects of clubfoot detection and management will be discussed. I believe that this is a visible birth defect, and since we already have the Rashtriya Bal Swasthya Karyakram, RBSK, under which we mandate that all the children up to the age of 18 years should be screened for birth defects, deficiencies, disorders, and development delays. We also have the intervention for newborn screening, especially now that almost all our deliveries are happening in institutional settings. Therefore, at the institution itself, a newborn screening can be done properly, and a whole lot of things which need intervention can be identified at the facilities itself. So therefore, my suggestion would be that going forward, all our delivery points and the health personnel working at these centers, including those in private sector, must be sensitized that screening for a clubfoot disorder should necessarily be done at the time of newborn screening. I think that's the best time when we can identify, and we have various further opportunities for identification. All the children are covered under the routine immunization program, where our health worker does get in touch with the children and physically gets an opportunity to see the children at least 6, 7, 8 times in the first year of life, and that provides us multiple opportunities. Apart from that, the RBSK teams also visit Anganwadis and schools. So in terms of the opportunities for early detection, I believe there's enough in place. Perhaps we just need to take a look and remove the constraints, and constraints such as lack of sensitization of health workers or at the facilities for looking for this, consciously looking for this as a part of the newborn screening, or as a part of the RBSK screening, or at the time, even if it is not a screening, at the time when the immunization is being done, if this defect is not noticed earlier, those are all opportunities when this can be noticed, and action can immediately begin. As Honorable Minister also pointed out, now there are techniques available wherein this defect can be completely cured, so to say, without the need for a surgery. And therefore, for that, whatever needs to be done should be done. Under the RBSK, we generally emphasize that the district early intervention centers should be fully equipped to render all the help to all the children who are identified, those who need help, and wherever necessary, referral linkages with medical colleges, etc., should also be set up. I can assure you that under the National Health Mission, our approach is fairly flexible, and we would be happy to support whatever resources are required for end-to-end management of children who unfortunately are suffering from this disorder, in order to make timely intervention to improve quality of life, and also enable these children to be able to lead a normal productive life. I at the end thank all, and especially the team of health department and government of Kerala for taking this initiative, and I'm sure that this would be taken up in a campaign mode, so to say. And going forward, we should have systems in place whereby we leave no one behind, and all the children who need this intervention must get this intervention. For that, whatever support is required from the government of India, we are here to support the state government. Thank you so much for this opportunity.
The organizing team, Kerala Health, thank the Honorable Minister for Health and Family Welfare, Veena George Madam, for giving the introductory remarks. And also the team thank the Honorable Vikash Sheel sir for giving his keynote address. Thanks to Sri Ram sir for presiding over the conference. Thank you. Then now Rajan sir, the Principal Secretary, and Dr. Manoj will lead the next session, Kerala Clubfoot program. Thank you. Invite Rajan sir and Dr. Manoj.
That's it. Honorable Health Minister, Madam Veena George, my esteemed colleague, Additional Secretary and Mission Director, NHM, Government of India, Shri Vikash Sheel, all other distinguished experts who have joined in this session from various places within the state, outside the country, and our distinguished guest. Along with me, our Dr. Manoj is there, and what we have planned is, instead of me doing some kind of a PowerPoint presentation regarding what we have been doing in the state of Kerala, what I thought is, along with Dr. Manoj, we will have some interactive session in which we will dwell upon what was the idea when Kerala Health has taken this initiative of tackling the Clubfoot program, and what we actually do at the field level. That will come, that will be told to all of us by my colleague, Dr. Manoj, who is practicing this at the field level. There are few points which I would like to stress at this point of time. That our Honorable Chief Minister, Shri Pinarayi Vijayan sir, and also our Honorable Health Minister, they have given us a mandate under Nava Kerala Karma Paddhati that we have to see all the disease burden. In the past, we used to say that from cradle to grave. But now the time has come that we have to see the prior to cradle. That means even before the babies are born, in fact, we need to take a look at whether there will be any kind of interventions which will be creating that impact on that health of the baby. And then eventually, in fact, babies will become the founding pillars of the society going forward. And post, in fact, when we say about the grave, in fact, one will ask the question that what happens after the death. In fact, there are now organ donation program. If unfortunately some road traffic accidents or other things are happening, and also there are other people, in fact, with motivation and also on their own, they are pledging their organs for the donation. So that means now we don't stop at only from the cradle to grave, but we go beyond that, and therefore the life continues. So with that kind of a message, when we have to do some interventions, in fact, we are having this one of the very good intervention with the partnership of Cure International, in which, in fact, Dr. Matthews and also Santosh George have been for last 1 decade in association with the Government of Kerala, Department of Health and Family Welfare, and also the Department of Medical Education, have been working on this Clubfoot 1 initiative. So what was the thinking at that point of time? The thinking, what I told right at the beginning, that we need to take a look at each and every aspect regarding the health. And from that thinking, there is a one very good tailor-made program intervention which started 10 years back. So Kerala Health has been in partnership doing what? They have told us that there are non-invasive techniques to tackle the clubfoot. But how do we do that? We have to have that capacities. So very massive capacity building program among all the like-minded people, orthopedic surgeon, pediatrician, and also our nursing staff who are committed to provide this service that have been, put to place. And in last 1 decade, that is continuously going on. It was not only for the health for functionaries, but also there is a one paramount role which counselors, in fact, they play in this whole scheme of thing. So counselors, team of counselors and their capacity building was a necessary integral part of this program. So with this kind of a setup, we were having 7 Clubfoot clinic, and we were having, in fact, we added one more. And these 8 centers, till date, in fact, they have identified 3,500 plus kids, and they are at a various stage of correction. But what we believe is that there may be a possibility that our outreach may not be that extensive, and therefore, rather than having only 7 centers, which puts a lot of stress on the families, so we should have a decentralized approach. So what is that approach, and what do we really do at the Clubfoot clinic? I would like to pose 3 basic questions, key question to Dr. Manoj, and I would request him, in his presentation, he would be touch upon on these 3 aspects and have a connect to explain that what we have been doing. As it is well known all over the world that Kerala has achieved the infant mortality rate which is comparable to any developed nation. What we have been doing in morbidity management of kids. So what do you think the area of the focus in context of disability, anomalies, and in Clubfoot in particular? That is the first question. Second question, what is your experience? In fact, the whole gamut of thing, as a policy maker, in fact, we will have a very good policy. Government of India is supporting us. State government is committed. We are having partners and we are having expertise. But what is your experience of what are the difficulties or what are the success stories of the Clubfoot clinic which motivates the team at the grassroots level? And what are the areas which we need to look at so that there will be further value addition? That is my last question, that learning from your experience, that what should be our value addition and the policy initiative we should take at this stage, so that whatever scale up we are planning to do, that we are planning to reach to 46 clinics in the shortest possible time, so that any family who is having, in fact, if a kid is born with a clubfoot, in fact, they will have in a shortest possible time with our fieldwork and outreach activity. And as Mr. Vikashil has mentioned, that right at the birthplace, if it is identified through that screening mechanism, if we provide the treatment, the success rate is very high. So what value addition you propose? So I will stop here and I will hand over the dais to Dr. Manoj to understand what actually at the field level we are doing. Thank you. Over to you, Dr. Manoj.
Thank you, sir. Respected Honorable Minister Veena George Madam, Additional Secretary Vigashil sir, Principal Secretary Dr. Rajan sir, Joint Secretary Srinivas sir, Babu George sir, my teacher Matthew Varghese sir, Santosh George sir, my seniors and my dear friends. The early detection of the disability and to give adequate care and early treatment to lead a disability-free life is the right of every child. As Sir has told earlier, we are very much achieved in the area of infant mortality rate. But it's equally important that all the child being born must be guaranteed a quality life by early detection and intervention of their disabilities. I have been working in association with the Clubfoot clinics for the past 9 years, and for the next 10 to 12 minutes, I'll be taking to explain to you my experiences which I had on the grassroots level. As the earlier speakers have told, the government food project, it was started on 2012. Now almost 3,500 plus babies have been enrolled in this particular event, and the numbers are still going up. Actually, from 2012 onwards, I was lucky enough to work in association with the Clubfoot Clinic under the guidance of Dr. Mahesh. At that time, sir was working in Kannur District Hospital. So frequent association with the Clubfoot clinics gave me more confidence and motivation to deal with the more Clubfoot cases. Again, in 2017, I was invited for a global conference which was conducted by the Cure International. And after the conference in New Delhi, soon after, the first thing I was to do, I could start a clinic in my parent institution, that's Trikaripur Taluk Hospital. We have been conducting the clinics for the past 4 years, and it's running smoothly, and the feedbacks are good. The one good thing while starting the clinic, what I have noticed was that at that particular time, I was the medical officer in charge of that particular institution, and it was pretty easy for me to convince my higher officials about the need of the clinic, and all the administrative issues were easy. From there onwards, we are conducting the clinics and we are conducting the awareness programs, because many of the public, they don't know such a clinic being conducted in our area. The sad fact is, some of or most of the private hospitals, they don't know. When they identify a Clubfoot baby, they still don't know where the baby should be referred. We have seen patients referred to different neighboring states like Mangalore, where the people go there, take the treatment in half bed, they come back for the treatment to our institution. So the awareness was a key need, and what we did was we used to conduct Clubfoot clinic days, Clubfoot days, and the family get together for the Clubfoot parents, and advertisements and short social media videos which made some impact on the society. Now, whenever a new child is being introduced to our clinic, we used to ask them, how did you came to know about this clinic? So now the people have started telling, like, we know about this clinic in our area, our ward member, they recommended us, or maybe there was some local people who used to introduce us, or they used to tell us about this clinic. Usually, majority of the cases are being trained to our clinic by the District Early Intervention Center. But again, some of the patients, they are being referred by the local people itself. We see it as a positive point of our clinic. And children from almost 70 kilometers make weekly visit to our clinic. This is the only clinic in Kasaragod district, and the border we share with Karnataka, it's around 70 kilometers from our place. There are children coming from Manjeshwaram. They travel all the way, like around 70 kilometers to one side to reach the clinic to change their plasters. So, as Sir has told, need of new clinics, at least one clinic every 40 kilometers is the need of the hour. As Matthew Varghese sir has detailedly explained, Ponseti method, it's the gold standard method, and we should promote in every aspect to continue and to start with the Ponseti method, which is being time proven. It's the more economical, and the outcomes are the best in the Ponseti technique. Training for the resource person. We should train more orthopedic surgeons for the sake of starting new clinics. But rather than giving a 1 or 2 day workshops, it's better they should be given a chance to or opportunity to work in hand with the already established Clubfoot clinics so that they will be also rewarded with more confidence while seeing more of the complicated cases. There are, as you see in that picture, that's Dr. Dinesh. He's from Mattanur. He used to visit our clinics in the sake of attending and getting trained in Clubfoot things. Actually, although we don't have a designated clinic in Mattanur, sir is seeing many of the Clubfoot cases. So such potential areas can be identified and easily we can start clinics in those areas. It's equally important to train gynecologists and pediatricians, and the awareness must be brought in between them about these ongoing government projects. As I earlier told, even if they happen to detect an early detect a Clubfoot case, many of the times those cases are not referred to the Clubfoot clinics in the government setup. Again, sonologists must be trained for the early detection of the Clubfoot cases. Many times the cases are detected in the early phase. They are referred to the Clubfoot clinics, but it happens like that they don't reach the clinic. 2 days back, I had a patient. The baby was 1 month old. It was a established case of Clubfoot in both the lower limb, but still the baby, they didn't reach the clinic because they had some financial problem and they couldn't find the money to reach our clinic. So such missed out cases should be eventually monitored. There must be a system from our side that our health staff and field workers can monitor the case and drain all the relevant cases to the Clubfoot clinics. As the earlier speaker has told, district early intervention centers, RBSK nurses, ASHAs, junior public health nurse, junior health inspectors, all these classified groups, they do routine home visits where they can meet the babies and the mothers and make sure that at least the babies don't have a visible skeletal deformity. Usually the ASHAs and the JPHNs, they make routine visits to the pregnant ladies, but usually after once the baby is delivered, they stop it and all the conversation may happen through the telephone. So it should be mandatory that anybody from the health service side should visit the newborn baby and further screening should be done. As I told, not all cases identified reaches the designated Clubfoot clinics. There are many reasons. One, as I already mentioned, it is the financial issue, because many people who are coming from 70 kilometers apart, they find it hard to find the money for the taxi or an auto rickshaw. The last case I mentioned, that baby who reached 1 month late, actually they could make up to the clinic because they were helped by the ASHA and that medical officer of that particular area. If I am correct, it was from some Vellarikunda. That was a tribal lady and a tribal family, and with some tribal funds, they were arranged a taxi to and fro by the doctor and the other health workers so that they could reach their clinic. They were promised that they will be given the same facilities the coming week also. So there are some religious issues and family issues, like the mother is willing for the treatment, father is not so interested. I have seen such cases also. So study these reasons separately so that we can make out, and that will help us to decrease the miss out cases. As I told this point earlier, the private delivery points are not being screened by our health staffs. Private delivery points should be more sensitized regarding the government projects and programs, because many a times the poor patients may not be affordable to take a treatment from the private sector. At least such patients should be drained to the government setup, and for that more awareness must be created among the gynecologists and the pediatricians who are the first to see the newborn babies. It's like public awareness, advertisements in the public media, short videos, newspaper advertisements, everything does good, so that the people from the community itself refer the patients to our clinics. Counselors, these are the inevitable part of the Clubfoot clinic. Only just our confidence and the motivation does not work. Because me being an orthopedic surgeon, it's usually we have a heavy OP, we have to manage the operation theaters, we have to go for the rounds. In addition with that, we get a lot of extra duties. If I see 15 babies a day, I will have to put the plaster up to maybe some 15 to 20 if it's some both limbs. At least 10 of their parents will give us a call back what to do further. There is small color change in the limb. Is there any problem? Baby is crying. So to handle all these calls, it itself is hectic and it's not practical. Usually this side is being totally handled by the counselors. It's just one part that the counselors handle. The first thing in the morning usually we see in the Clubfoot clinic is a desperate parents. They have been waiting for 9 months for a baby. They comes with a newborn baby. Soon after delivery, they are seeing that the kid is having a congenital anomaly. That itself, they are desperate, they are desperate, they don't know what to do. This part is well handled by the counselors. They counsel the parents. And as far as I know, in Kerala, in our setup, women education is high. They just want to know whether this is a correctable problem or not, whether their kid will be roaming around like any other kid. But in northern states, I've heard like this is the cause for a fight between the daughter-in-law and mother-in-law. There is where the counselors usually put more of their effort in counseling the mother-in-laws. They usually blame this on the daughter-in-law. So there starts the role of the counselors, and these counselors are the major helping hand in applying the cast. Again, after 3 months of serial casting, tenotomy, and once the plasters is removed, almost the foot looks normal. Usually, not usually, mandatorily, we give them a shoes which has to be worn for next 5 years. Like after 2 to 3 months, gradually the parents, they used to think, why now the shoes? Why to make the baby more suffer? So we have to repeatedly explain them, this shoes is going to hold the baby's foot in the particular right position. You have to continue with the shoes. This part is also handled by the counselors. So whenever we are about to start a new clinic, the role of counselors must be guaranteed in each and every clinic. Now we are doing the documentation of the Clubfoot clinics in the papers. But it's for time. I think already some software has been developed and we can introduce the software. But using a newer software, it can lead to using all these data for statistical analysis and further studies in the future. And using a software will decrease the amount of workload in the OPs. As I told, there are some reluctant groups, especially in the Northern Kasaragod district. So these groups should be addressed by the health service or the health people. Like we have many programs like Indradhanush, where the people are reluctant to take immunization. We used to counsel them. We used to go to their homes and explain the details. So such a strategy can be implemented in these Clubfoot cases also. Regarding the new clinics, what personally I have felt is like we should find apt areas to start a clinic, preferably where there are more than one orthopedic surgeon. Again, a single orthopedician dealing a clinic, it's hectic. You can't move out that particular day. You are engaged there. Always as an orthopedician, I thought like whenever we meet with a complication, if there is somebody else to deal and discuss, it's more comfortable. As far as Kasaragod is concerned, as I told, it's around 70 to 80 kilometers from the northern border. So if we can have a clinic at 40 kilometers apart from Trikaripur Taluk Hospital, it will be good for the patients coming from the northernmost Kasaragod district. Already Kasaragod General Hospital, it's a well-established hospital. Dr. Mahesh, he was my mentor and trainer in this Clubfoot. He's working there. So if we can start a clinic in Kasaragod General Hospital, we can find another clinic in Kasaragod district apart from Trikaripur Taluk Hospital. From Trikaripur towards south, we have, after 40 kilometers, we have one more clinic in Kannur District Hospital. But after Kannur District Hospital, the next clinic comes at Kozhikode Medical College. That's around 100 kilometers from Kannur District Hospital. So in between, if we can find one clinic somewhere in Vadagara, Taluk Hospital or something, in that way, if we can spot some relevant spots and prioritize that particular locations for the new clinics, it would be more worthy, I think. And as I told, Dr. Dinesh from Mattanur, he's towards the eastern side of Kannur. It's around like 40 kilometers from Kannur district. So if we can start one clinic there, there are some more names which I can identify, like Ajmal, who already had some training in Clubfoot things. But when it comes to the southern Kerala, I am not so familiar with the names. But that strategy may be do further good. At times, I have felt like the NGOs like Cure Clubfoot, which are in association with our program, they're doing a great work, but at times there are areas where the counselors were not, because of the fund shortage, the counselors were not paid sometimes, and we had shortage of the documentation papers. So there are many NGOs who have approached us, like they will adopt a clinic and they will sponsor the clinic. And I've seen it working beautifully in New Delhi. Like Rotary clubs adopting a particular club and particular clinic and doing it. So it can be thought about. And we have now a WhatsApp group for the parents. Actually, all the messages has been will be given through the WhatsApp groups. And for our communication, the WhatsApp group does a good thing. But another good part is whenever a new patient, whenever they have a question, they pass it in the group. Automatically the question will be answered by some other parent. And they used to post the photos of their babies walking around, running around. So this gives a confidence in the parents whose children who have recently started the treatment. And usually we once in 8 months or 10 months, we used to keep a WhatsApp meeting for the parents there, and we asked their suggestion. All of these things, some of we have discussed, they have told, but most of the time they have told they need clinics in near to their house, like rather than traveling 70 kilometers. A newborn baby traveling for 70 kilometers to reach the clinic at 8 o'clock, usually they start at 6 or 5:30 from the morning. And sometimes due to some renovation problems and the infrastructure problem, we couldn't provide them with the feeding room. Actually, we are dealing with the feeding kids and the feeding mothers, so feeding rooms are mandatory. And one another thing they told was they're traveling a long distance from the longer distance areas. So when they reach a place where there is no canteen, especially when there was corona was in the most prevalent manner, even at that times we were continuing with the Clubfoot clinic, as Matthew Varghese sir was told. We never stopped the Clubfoot clinic. But at those times, these parents and the kids, they were finding hard to find some food. So they told, like, if the hospital had a canteen facility, it would have been good. So out of my experience, the take-off message is identify all the Clubfoot babies. We should not miss even a single one. Even if we diagnosed it, we should take steps so that each baby reaches the clinic at the earliest. As sir told, like we start the treatment earlier, the outcome will be the best. There are need for new clinics, and the introduction of the new documentation software will do for this project. These are the real-time photos, like we took it from our clinics itself. These are my humble observation. And once again, I thank the organizers for giving me an opportunity to share this platform. Thank you. Thank you once again.
Yeah, thank you, Manoj. Manoj has given us an overarching idea that what actually is happening at the Clubfoot Clinic in any place where we are setting it up. So few points, in fact, if we have to think over the feedback. One is a scale up is very essential, because we don't want these families who are already under stress will be more at stress for traveling a lot and related various issues. So therefore, our honorable, minister has given us a guidance, and we are now going to scale up Clubfoot clinic all throughout the state. To begin with, we will reach to the number of say 45 clinics, 44 to 45 clinic. And by taking a clue from actual realities, in fact, we will have a hub and spoke model. Whether we can have a hub and spoke model for a primary level of interventions and some of the other interventions, whether we can do it at a spoke, and in that way, in fact, we can have a multiplier. In fact, we are having 14 districts in our state, and by having the number taken to say around 44, 45, we will have a good penetration within the district. But we will also not stop at that point of time, because based on the evidence, if it is required more replication, we will think about it, because RBSK program also allows us to do that kind of an investment to ensure that no one is left behind. Second point which comes out very strongly is the engagement with the community. In fact, we don't deal only with the mother and the father of that baby, but we will have to deal with the family and also elders in the family and also society. Because 2-3 points what he has very nicely narrated, which are related to not only the ignorance regarding the correction is possible, but also there are some kind of a misconception and some kind of a religious issues which come into play, or their understanding regarding this at a different level. So therefore, our engagement with the community, and that too by experts like counselor, is very, very important, and we will take extra care to have a very good capacity build counselors all throughout. That is our, we will have to have a thinking on that. So basically, when we expand, we need to ensure that the outreach and the field activities will happen continuously. In fact, we identify the baby, we bring them, link it with the care and support, and after that the follow-up. Missed out baby, again identification and care and support linkages and a follow-up is required, a continuous effort at the field level, and we are very confident. Our RBSK nurses and also our JPHN, JHI and also ASHA workers, they have been continuously working on this with some kind of a qualitative improvement. I think we will be able to succeed in our endeavor of having no one is left behind. Bottom line of any program is definitely capacity building and also awareness. So awareness building among the masses, that we will do. Second thing which I would like to pose before all the experts who are present here and also attending online is, we would like to make this as a one program which gives hope to all the families related to Clubfoot. But also there are other families where they are having babies with other congenital anomalies. So can we piggyback on the method by which we tackle Clubfoot issue and give that hope to the families who are having other congenital anomalies? And therefore, we need to develop a program for other congenital anomalies. There are almost 29 conditions which have been identified, and whether these 29 conditions are having linked care and support program, that should be our constant thinking, and to what extent in fact we will be mobilizing public health approaches, thereby we give that much needed support to these families. So we look forward to our association with each one of you from wherever you have been joining, and looking forward to your continued support for all the endeavors what Kerala Health is planning to take. So with this, we stop here regarding our Kerala initiative. If there are any kind of questions which has come online, in fact, we will be willing to take, because I think there are 4 or 5 minutes left to close our session. If there are no questions, in fact, we will stop it here. Thank you very much.
Thank you, sir. Now we move on to the next part of the session 2, Clubfoot, non-invasive management, civil society and government partnership. To begin the session, we are happy to have Dr. Santosh George, Director of Cure India, to share his experiences on the Cure India model. Over to you, sir.
As I share my thoughts, I just want to really express our sincere thanks to the Honorable CM, Chief Minister, for very encouraging thoughts and his message. The Honorable Health Minister for giving her assurance to make this initiative successful. The very respected Principal Secretary Health for his guidance and passion. Joint Secretary Dr. Babu George, who has been very constantly working hard to make this conference successful. And I should also mention this, Dr. Matthew went outside, so I can tell this. Till 1:35, we were actually having some discussion, and then we all went for lunch. So now I realized he didn't take lunch. He didn't take lunch because he had a session at 2 o'clock, so he immediately got into the session and just wanted to make sure that he do it very well. And today, when he presented, I was counting, and it was 95th training program that he shared. And I was lucky to travel with him for at least 85 training program. So whatever I have learned in the field of Clubfoot is actually attending Dr. Matthew's training program. In your absence, I told you didn't have lunch. So, see, the vision for us. I heard about Clubfoot in 2008, and I didn't know anything about Clubfoot because I never worked with a Clubfoot, even though I was in the area of development for so many years. But when I heard about Clubfoot, when we saw these children and the excitement, we started with the Delhi program. We are fortunate to get this insight to work with the public system, because the advantage of working with the government and the public system is when we start a program, we are able to immediately reach out to thousands of children instead of creating institutions parallel. So this is the best model we have learned, and that continues to be the Cure India model. It's a policy decision that we work with the public health system. So because our vision is every child should get treatment for Clubfoot. And we want to create a public system so that in the future, even if Cure International India is not there, the public system continue to treat these children with Clubfoot. In 2017, we had the Global Clubfoot Conference where the Honorable President of India came, and he gave a statement. In fact, it was a kind of a calling. He said in 2022, India celebrates 75 years of independence. It should be our resolve that by then we create a system where every child born with Clubfoot receives timely treatment. We were actually kind of so much inspired by this, and we were moving forward. Unfortunately, the COVID has really slowed down that process, but we are very happy that Kerala state has come to make that vision a reality. I have to acknowledge openly that it often takes one committed officer actually to make such an extraordinary change. In October, I think September, October, when I met Dr. Rajan in his office, he asked me what next in Clubfoot program, and I said it'll be good if there is a system in Kerala that every child will be treated. He said that's what we are looking for. And today, in the next few months, we are sitting here and it's already a reality. So I strongly believe that this vision we had is going to be a reality at the national level very soon, because other states are definitely going to follow the Kerala model. For Clubfoot, I think Kerala model is going to be a kind of a game changer. 2009 we started, and 2010 we signed agreement with the Delhi government. It took 1 year for us to convince them, but it was very easy. 2 reasons. One, in the first year we planned for 300 children in Delhi. We got 850 children. In fact, I still remember the first training program we did was in January 2009. We expected in a hall like this around 30 orthopedic surgeons. We got 80 orthopedic surgeons. So we realized that there is some real kind of need. And adding to that, later we realized in 2012 when we had the 2-year celebration with the Delhi government, Madam Sheila Dikshit, the then Chief Minister, she said she was born with the Clubfoot. We didn't know that. But in the meeting, she declared that she was born with the Clubfoot. And so she wanted Clubfoot program in Delhi to be very successful. So we were lucky. And By 2016, Cure International India signed agreement with every state in India. So no turning back. We worked day and night to make that vision a reality. Today, we are in 240 locations. You go to any government medical college in India, there will be a Cure Clubfoot program. And we are now kind of managing 324 designated Clubfoot clinics, because in some locations, there are multiple days. 76,000 children, and on average, we are adding 1,000 new children every month. Is this enough? No, because if you want to really kind of reach to every child to be treated on time, we have to really focus on 40,000 children every year. Because in India, 27 million children are born every year. So if you take the global number, one Clubfoot child for every 800 live births, at least around 40,000 children are born with Clubfoot in India every year. That's our target. Long way to go, but in 10 years, in Kerala, if you are able to come to this day, we truly believe in India, we will definitely reach to that day one day. We always tell that in our lifetime, we will be able to eliminate disability from Clubfoot. I was just interacting with an Indian origin, born and brought up in New York. This person, his name is Rahul. He underwent 9 surgery in New York. And at a later stage, he came as a volunteer to work with Cure India. And after visiting some of our clinics in Delhi, he finally said one statement, which is very important for us. He said, I would have been very lucky if I was born and brought up in India, at least for my Clubfoot. So if at all you have a doubt that what we are doing in India is kind of not so good, because we always have this kind of misunderstanding that the best things are somewhere else. People who have experienced, because sometimes it is better to have, better to learn things in a later stage, not to make that mistakes. So that Rahul's experience should not be there for any child. That's why we are promoting Ponseti method as much as possible. Now, what is this Cure India model? 12 years, we could expand to this level. If you really look at that graph, it is very steep, because we have a very tested model. In India, we are lucky because we avoided all the failures what the world actually committed when it comes to Clubfoot management. Because we heard for almost 20 years, leading organizations were going around the world training doctors on Ponseti method, training. But unfortunately, nothing worked, because it took 20 years for them to learn that training alone doesn't work, because often these doctors didn't know where to send their children for the brace. Often the doctors didn't realize that the parents were not coming back, and there was no system even to document this, so there was a lot of problem. So what we did, how we came up with this Cure India model for Clubfoot management, we did a study. We understood doctors are treating children with the Clubfoot. It is not that doctors were not aware of it. Doctors were treating. So what are the 4 things that were already there? Doctors were there. Treatment material is there. Excellent clinic space is there. And system to identify and refer. System to identify and refer. That is the Ashas, Anganwadis and others. 4 things are already there. And we didn't want to kind of duplicate that. What is not there? Doctors are there, but there was no proper regular training. The Ashas and Anganwadi people were identifying and referring, but once the child come to the treatment, once the child start the treatment, then there was no document. So the documentation was there earlier, identification and referral. After that, there is no documentation. So, and then the third one, for casting the materials are there, POP, soft band, but then the foot abduction brace was not there. So each one of them we studied. So we said, as an organization, we will give 4 things. 4 things are already there. Doctors, system to identify and refer, the treatment materials, and the clinic space. We said we will train the doctors, We will document the entire details for every child for the entire treatment using Pirani score, and we will distribute the foot abduction brace, and we will appoint counselors. Because majority of the orthopedic surgeons said they do not have time to answer all the questions these parents ask. And they do not have a system to follow up with every child and make sure that they come back and complete the treatment. So we said, okay, if Ponseti method is failing because of these 4 reasons, as an organization, our role will be to provide that. So 4 things from government, 4 things from Cure India, put together, this model has worked beautifully well. And this, we believe, if we do it for some more time, 12 years we did, in Kerala we have been doing it for 10 years, we definitely believe that one day soon we will be able to say that disability from clubfoot is completely eliminated. Since we do not know the reason, we do not know the cause for clubfoot, we will not be able to prevent. Children will be born with the clubfoot, but what we can do is identify them on time, make sure that they are given treatment so that no child will be left without treatment. I just want to really thank and appreciate the government of Kerala, and also I want to acknowledge the support we receive from our international faculty. I'm very happy some of them are already online. Ross from GCI, Dr. Shafiq Pirani, Dr. Norgraf Penny, and Dr. Ahmed, and our friends from Delhi, AIMS, Dr. Venkatesh, and Dr. Vikas Gupta from the Safdarjung Hospital. Dr. Pirani, I can see you, and I know it is maybe 4 o'clock something in Canada. You were there when it was 10 p.m. in Canada. You are there again when it is 4 a.m. in Canada. That shows your extreme commitment, and we want to see you here soon. Let the COVID be over, and then we will see you in person in Kerala soon. Thank you so much for this opportunity.
Thank you, sir. I now invite Dr. Shafiq Pirani to deliver his talk on the Pirani score. A few words about Dr. Pirani. Dr. Pirani is a clinical professor at the Department of Orthopedic Surgery, Division of Pediatric Orthopedics at the University of British Columbia, and practices at the Royal Columbian Hospital. Dr. Pirani is widely known for his clubfoot assessment tool, the Pirani Clubfoot Severity Score, for his pioneering work on how Ponseti method corrects the clubfoot deformity, and for initiating the movement for use of Ponseti method in developing nations. We welcome you, sir.
Thank you very much for your kind invitation. If I might just share my screen. Is it possible to do that? I have some slides. Can somebody allow me to share my screen? I'm very thankful to the organizers for asking me to participate. I think this is going to be a tremendous, noble exercise that the government of Kerala is embarking on. There we go. I was asked to speak on the Pirani score, but once I got to understand a bit more about the what the nature of this conference is about, with license, I've decided to change the title a little bit about the Pirani score and quality assurance. Some 30 years experience, what have I learned? And I've taken the liberty of adding Pankaj Jain, a technologist, to this talk, and you'll see why, because I think that there may be some things here which would be of tremendous interest to the effort as we go on. My thanks to the Chief Minister, to the of Kerala. My thanks to Smita Veena George, the Honorary Minister, as well as the various other dignitaries who participate in this noble exercise. I see that the theme of this conference is Clubfoot Free Kerala. None shall be disabled due to clubfoot. That's extremely noble, and I really do want to participate and join, if I can, with you in this noble exercise. I see your goal is wide awareness in public government about the Ponseti non-surgical treatment to change the practice of your field functionaries. And the outcome you desire is qualitative changes in early detection with appropriate non-invasive management of clubfoot, and to increase your number of clinics as stated from 7 to 44. But this is quite a challenge. Why? It's because if you truly want to do this, every child that is born needs screening for foot deformity at birth, and the positives need to be referred to a clubfoot clinic. Then each referred child needs to be assessed to confirm whether the child has a problem or not. And then each of the estimated, and according to my calculations, 400, but maybe less, maybe more, children that are actually diagnosed with club feet in Kerala each year need 5 years of treatment with a minimum of 25 clinic visits over that period of time. And therefore, if my calculations are correct, 7,000 children diagnosed with club feet will be in the system at any one time. And for success, they all have to be followed. They all have to be monitored. They all have to be treated. If none is going to be there with disability at the end. That's 5 years of treatment. I started my clubfoot life performing surgeries, but it was in 1995 that I converted the Ponseti method. This is non-surgical method, and I developed the Pirani score. And there were some reasons for this. The first thing I want to say to you is to compare the results of surgical treatment with the results of Ponseti treatment. And these are both studies comparing 25-year outcomes. And it's quite dramatic that when you look at data after long term, you see that the surgical treatment has 67% good and poor outcomes, whereas Ponseti treatment has virtually the opposite, 78% good and excellent outcomes after 25 to 30 years. And this number is important. Actually, surgical treatment should be considered a failure of treatment. If no surgery should be done on a child born with clubfoot. It's not the right thing to do, it's the wrong thing to do. And these are the results that prove it. And Santosh, you mentioned the child who came from New York. And this is exactly why the problem happened to that person in New York. So what you're doing in India for clubfoot with treatment with the Ponseti method is actually world-class standard of care. The other thing I noticed is that people, even though clubfoot has been around for 2,000 years, been recognized and treated, there wasn't really a good ruler to measure the amount of clubfoot that was present. And if you don't have a good ruler, a good way of assessing the amount of clubfoot, then it's difficult to know how you're doing. And so in the 1990s, I developed a method of scoring the clubfoot, which is valid, which has been shown to be valid and reliable. And the Pirani score is not a classification. It's a ruler that assesses the severity of deformity at each visit. And if you can assess the severity of deformity at each visit, then that assessment will facilitate clinical decision-making. Is the correction progressing satisfactorily? Is the tenotomy indicated? Is bracing indicated? Is the deformity relapsing? Very important questions that the clinician and the parent wants to know. How are things going? I won't go into the details of it, just a few summary slides, but it's based on a simple observation of the foot, nothing complicated. It can be done in a minute. There are 3 signs that we look for in the hindfoot, 3 signs that we look for in the midfoot. Each sign is scored 0, half, or 1. It's easy to see. So for example, this would be the curvature of the lateral border, 0 being straight, the outside of the foot, 1 being a very curved foot. Something at the back of the foot we look at, which is the crease at the back, similarly 0, half, and 1. And even though these signs are very simple to look at, we've investigated them very, very thoroughly by comparing the clinical signs with MRI pictures of the feet, and this has shown us our validity and our reliability. And you can see here an example of a foot in my clinic where this particular foot scored 3 in the hindfoot, 3 in the midfoot, 6 for a total score. And then after some casts, the foot looks relatively straight. So the midfoot is corrected, but the hindfoot is still tight. It won't dorsiflex so much. And then once you do the tenotomy, the foot corrects completely. And so you can see how the scores can tell you where you're heading. And you can actually make a graph. You can make a Pirani score graph. And this is a schematic graph that shows you on the left the Pirani scores and the weekly casts that are happening, and you see the change in the shape of the cast. You see the scalpel blade that denotes that tells you when the tenotomy should be done, and you see the components here. That's the total score, the hindfoot score, the midfoot score when the tenotomy should be done, the last cast, and the bracing. And so the color changes show you when the foot is uncorrected, when it's correcting, and it's when it's corrected. And these are the weeks in treatment. And the nice thing about this graph is that it shows you various things. When should things be done? For example, the tenotomy here should be done when the midfoot score is less than 1 and the hindfoot score is 1 or more. Similarly, this particular case here didn't require a tenotomy. So about 10% of cases are like this, where everything corrects nicely together. And then there are sometimes you have to ask yourself, when is bracing indicated? And here are the indications for bracing. And then sometimes you see there's a problem with the casting and the score goes up. And this graph allows you to monitor how things are coming along. Sometimes the brace isn't worn and there's relapse. So the score shows you that relapse is happening, etc. And there are some very difficult cases when you have a syndromic clubfoot where the response is slow, but you can still get to where you need to get to. So this we developed in the 1990s, and it was there really to help me understand how to treat a foot better. I could understand what was happening in the foot. But it's not really about just treating one child with a clubfoot, the orthopedic surgeon way. It's really, my journey with clubfoot has been allowed me to come to the intersection of clubfoot with public health. Why? Because I was born in Uganda, and I was a victim of Idi Amin being thrown out of Uganda with my family in the 1970s. And I went back in 1998 after 26 years away, where I met Dr. Penny, who was working there as an orthopedic surgeon. And Dr. Penny expressed to me his dissatisfaction with the results of surgery. And we decided together to bring the Ponseti method to Uganda. And we did a project in Uganda. We called it the Uganda Clubfoot Project, with money from Rotary International. And we taught a lot of people to do clubfoot in Uganda. And with the last little bit of money, when we actually asked how are things going, we found that simply training training wasn't enough. That many people needed the support of the system from the Ministry of Health, etc., from their institutions to be able to practice what they had been taught. And so that led to my next effort in Uganda, which was with the Uganda Sustainable Clubfoot Care Project, which is funded by the ministry, by the Canadian government, where over several years, we then built systems within the Ministry of Health to build capacity for the for the teaching of clubfoot through their schools of healthcare, as well as through their hospitals, where we opened clubfoot clinics in all the public hospitals. And we were very, very pleased to see that as the years went by, the number of children that were actually treated increased to reaching probably about 70% in 2011 of the total number of children that will be born in that country with club feet per year. And actually our efforts were recognized in the World Report on Disability published in 2011. And then I was involved in a similar exercise in Bangladesh, where I was invited with my team to go to the Ministry of Health, to go to Dhaka and to set up the Sustainable Clubfoot Care in Bangladesh project. And this recognizes the entire pathway that I was talking about, that you need to have screening in the community, referral, diagnosis, treatment, all the way up to discharge. And what we did is we supported the activities of the Ministry of Health and Family Welfare in terms of training and surveys, etc. And we did one other thing, is we developed policy. So this is the document, the National Strategy and Guidelines for Clubfoot Care in Bangladesh that we developed with the Ministry of Health and Family Welfare. To say how the clubfoot the clubfoot should be treated, but how should clubfoot teaching and treatment be organized in Bangladesh? And one other thing we did is we developed a patient record. This was our Ponseti Training Center Clubfoot patient record form, and it recorded all the details of the child as well as the treatment, so that we wanted to follow how we were doing. And this data, this data was very good because it allowed us to be able to have dashboards of key performance indicators. So here, for example, is one of our forms that all the clinics that we were seeing, well, the number of children that we were seeing, the feet under treatment, and then we had our key performance indicators in colors. So you could see where you were going wrong, which is red, where you're doing well, which is a green, et cetera, et cetera. But this data all had to be put in retrospectively. It was recorded on paper and was put in retrospectively, and therefore its reliability was not as good as perhaps as if the data could be put in real time. But we didn't have the necessary technology available to be able to do this in real time. And this is where I've arrived now at the Ponseti Clubfoot Navigator. And I'm very excited by this because in the last little while with COVID, I haven't traveled, but I've been able to at least continue contributing to try and make it better for the child yet to be born somewhere in the world with Clubfoot. And this is where I want to tell Pankaj Jain's story, and hopefully Pankaj can be online and tell me if I'm going wrong somewhere and assist me with the technology. But Pankaj is a technologist in Delhi who had a personal experience with the healthcare system in Delhi where something went wrong and there was a problem. I don't know the details, but suffice to say, being a technologist, Pankaj asked why. Because the guidelines said that something should have been done and it wasn't done or something like that. And Pankaj asked if he could bring technology to bear to help improve outcomes and reduce errors in the healthcare system. And he tells me then that he sat next to Matthew in his clinic for 18 months every week, understanding the Ponseti method, so he could encode the Ponseti method into his machine, into his algorithm, develop an algorithm for the machine. And I met him in 2017 at the international conference, and since then I've been part of the team helping make this technology better, making it more robust in terms of its algorithms, better user interface. So what is it? Well, it's a web-based app which has the medical record. It's for real-time data entry by the clinician. On any mobile platform, its user interface is quite friendly. And the excellent thing is that it provides clinical decision support from Ponseti embedded algorithms. And what I would like to do now is to do a bit of a demonstration, if I can. I'm going to switch to, if I can switch, let me just see if I can do this. There we go. So here it is, okay? We are live right now on the Ponseti Clubfoot Navigator. And what I have here is a patient record. If you can all see this, this is, the name of the patient is Kerala Demonstration 1. He's a 4-day-old boy, and this can be done on your in real time in the clinic, as long as you have a 3G signal. Internet access is necessary. I've already created the record with a general history that is everything is normal. the general examiner. Actually, no. We're going to. This is visit number 1. He's active today. We're going to start the visit, and once the internet gets going, you'll see. There we go. This is how you put the scores in. Okay, so these will be the Pirani scores. The history and general history and examination is already in, but this is how you put the scores in. You measure the angle, passive ankle dorsiflexion angle, which is quite important to measure. It's just a clinical item. Now, once I press save, over here, all the details for this left foot will go to Pankaj's server, and back comes the recommended treatment. So if I am a junior somewhere and I'm not sure exactly what I should be doing, this actually tells me that the correct treatment is a Ponseti cast. And of course, there are a number of other things that could be done. These are all the smorgasbord of treatments that could be done. The asterisk there gives us the recommended treatment. It's a recommendation. These are the scores that justify why this should be the treatment. It tells you actually the reason why here for correction of midfoot deformity. Now, once we accept that is the treatment, then we save, it tells us how to put the cast on. It gives you a little video. It's got the principles of how to put the cast on, and we are making videos that would actually show us how to put the cast on. So it can really help not just in the clinical decision making, but also in the actual technique. And then what it also does is that it allows you to record what was the result that you got from your treatment. So, you can write down here the record of the treatment. And the good thing here is that once you record that, the algorithm then actually measures, did you achieve what you wanted to achieve? And if you achieved what you wanted to achieve, then it goes on and suggests the next clinic date. If you didn't, then it'll ask you to do it again. So this is a way that you can have quality control. And then you can end the visit. And that will be an example of the first visit. But now I'm going to take you to another record, which I've created. This is patient Kerala demonstration 2. You can see this child is 1,392 days old. You can see here the details of the general history and the general examination.
Yeah.
You can see here the Pirani score graphs that are
blue?
already embedded.
Oh yeah, I could do that.
And the angles, they're
Okay.
right here, okay? And if you want to have the details of any of the previous visits, they're right here. Why am I showing you this? Because this is, I think, the way that large programs can capture the data in real time, and then this data can be looked at after the fact by the administrators to see how the individual clinics and how the individual performers are going, so that you can have your key performance indicator dashboard running very easily. So I think I'm going to stop there and see if there's any questions. Thank you for your time. And I do want to commend, before I finish, I do really want to commend the government of Kerala and the extraordinary vision, incredible vision that you have in wanting to do this for your children, for your population. I applaud you. Thank you so much.
Sir, we have a question.
Yes.
Sir, is this software available freely available?
Yes, the plan is Pankaj and our vision, the developer's vision, is to make this widely available for free. This is not, we are not interested in making a profit. We're interested in making a product that would serve the population at large. We need to have something to be able to manage and to administer the system, because when you have a large amount of data, and maybe Pankaj, you can contribute here as to what you think it would take. But whatever, we need to have a system that would allow it to run well, to serve the purpose of the administrators to know what's happening, to serve the purpose of the doctors so that they like to use it. And we have experience with parents in Canada who have seen this, and they want something like this also to let them know what's happening to their child. And we can link it. It can be linked to a patient portal so that the parent can see how their child is doing. They can have specific instructions for their child so that if they have any concerns or problems in the middle of the night, they know what to, they have some avenues to find out what can happen. Yes, I think that's what we're aiming. Pankaj, what do you think?
So yes, I mean, our overarching goal is to improve the paucity care delivery and to reduce medical errors, improve outcomes. The only sort of funding that we would require is to ensure that we are able to roll out this software in a more organized manner, and we are able to provide proper support. We can grow this further. But this initiative has not been part of like a for-profit enterprise. This is really the goal is to improve the paucity method delivery.
The idea is to reduce errors and to support clinicians in wanting to provide the best treatment they can.
Thank you, sir. Yeah.
Thank you.
Sir, we have one more question.
Yes.
It's not a question. So yesterday I was interacting with both Dr. Pirani and Mr. Pankaj Jain. So what they have suggested, since Kerala is taking this into a next level, we will introduce this Ponseti Clubfoot Navigator, PCN, in maybe around 5 to 8 select clinics in Kerala, and encourage doctors like Dr. Manoj and others who are very actively involved in it to use it. Because one concern they have is this should be used by the doctors, because the present electronic documentation procedure that we have is used by the counselors, and that is done after the clinic, because during the clinic they are busy counseling and answering the questions. So after the clinic they sit and do all this online documentation, whereas the one product that is come up now has to be done by the doctors in the clinic, so that even as they take a decision, they are guided with the advantage of the artificial intelligence. So we definitely will be able to launch this here. This is the best place to launch it. As Pankaj suggested, maybe 5 to 8 clinics, and there will be a person appointed exclusively for that to oversee and manage and see that it is working very well. So we are for it. So if you would like to add how and when we will be able to do it, I think that will be an excellent step ahead.
Well, if I may speak, yes, we can do this. We need to organize it. We need to have the proper training sessions for the people who will be using it at the sharp end. We need to support them. Pankaj and I can work out with we can have some Zoom sessions with the people who will be using it at the front end, make it available to them. And I'm sure there might be people within the ministry, information technology people, who might want to also participate and understand this process and perhaps figure out the ways and means. And Pankaj, what do you think should be needed in detail?
So in terms of the hardware support needed, it's actually very low. So this whole platform has been built in a way like the cost of hardware and supporting it on hardware is not very high, right? But what we need to ensure is that not just the software, but the whole program of using Ponseti method in the clinics, it succeeds, right? And for that, what we need is people who can do program management, who can ensure that people who are using it in the field, they're able to use it properly. They're also able to ensure that people are using it honestly, right? So it's something where whoever is using it is using it during the the treatment process and not afterwards. They are also engaging with us in improving this platform, because we know, like, when we launch something new, there are always some teething issues, and we want to make sure that this is something which is easy to use, and all the clinicians, they actually see advantage or they see some benefit of using it. So that's what we want to ensure, right? That it gets used, and then over a period of time, we will invest in improving this product, so that when we scale it up to all the clinics in Kerala, as well as if tomorrow we want to scale it up to some other conditions also, because someone earlier was mentioning that there are 29 congenital abnormalities that eventually the government of Kerala would want to address. Right? And some of them might actually be very similar to the Ponsity, to the Clubfoot condition. So that's how I sort of envisage that this thing could actually grow and have an impact.
It does require a change in behavior from the clinicians. And any change in behavior needs to be supported. Clinicians are busy people, and what we want to do is to make sure that they enjoy using this, and that rather than adding 30 seconds to the visit, it perhaps reduces 15 seconds, if we can get it right. But we need the support of the front-end clinicians to look at this properly in their clinics and spend some time upfront to understand it and get to use it and give us their honest feedback, make it better, make it work, so that it actually becomes something enjoyable that they can use, because it helps them do their job better. And the patients get better outcomes. Thank you.
Yeah. Dr. Pirani, in fact, it is well understood, Pankaj also. I was just talking to Santosh. What we will do is, along with our technical people, we will have one interaction, and definitely we will work it out so that we can work this navigator. There should not be any problem. So we will have one interaction with all of you so that we will understand the technicalities in detail, and we will go forward. It's a privilege and honor, in fact, for all of us to have you and also your colleague, Mr. Pankaj Jain, who have done, in fact, a very good transformation of the very basic requirement, so that I think community all over the world should be benefited to hone their skills and also do the corrections at the grassroots level. So the multiplier is huge, and we are really thankful that you have early in the morning at 3:30 in your place, in fact you are attending this conference, is a message which you are giving us and inspiring all of us here at the grassroots level to take the initiative forward. Thank you very much, both of you. Thank you.
My pleasure. Thank you.
I now invite Dr. Matthew Verghese, Medical Director, QR India, to talk about Clubfoot management, the public health model.
Thank you very much. Fascinating talk from Dr. Shafiq Pirani. What I have to say is not very different from what Santosh explained about what we are doing. We conceptualized the movement, as he mentioned, looking at public hospitals. And the reason was important. The numbers are huge. In 1.3 billion population, 30 million children born every year, 40 to 50, these are guesstimates, we don't know the true incidence, 30 to 40 to 50 million children born. Guesstimates are 10 minutes, one child is born with Clubfoot. The challenges were, health is a state subject. So every state has takes its own decision. So the state of Kerala takes a decision, but that doesn't mean that it gets translated to other states. Central government cannot order the state to do things. There is a national health mission, but it cannot order it. There's a lack of uniform health policy and prioritization, and the standard of care varies widely. These are challenges. The other challenges are human resources, and also many times the plaster material itself was not available in many of the clinics. So sometimes emergency plaster material had to be delivered there. The brace was a true challenge. Most of them would not get the braces. They would not get the braces. So the deformity would recur because the maintenance phase is as important as the treatment phase. So this had to be done. And the parents, many of them were not aware. Pediatricians, obstetricians were not aware. They didn't know when to refer the case. They would refer the case after 1 year. It's a very long time. And then, of course, access issues, rural versus urban. So many parents could not access because of the distances. They just couldn't afford the transportation. Remember, transportation meant the mother cannot travel alone, has to be accompanied by the father or some responsible member along with the child. So if it's a bus journey, even if the ticket is 50 rupees, 50, 100, child may be free, back and forth, 200 rupees each visit. The poor families cannot afford it. So what Dr. Manoj mentioned is very, very valid. They just do not have access so easily. So we need to create that access easily. Another thing, there is a need for a national policy on birth defects. The Rashtriya Bal Swasthya Karyakram was a major push for that, and challenging status of public health across the country has been a challenge which has been exposed and also used in the COVID epidemic. So we needed to understand this. This challenge has been that Clubfoot also was not on the national agenda. And in addition to the new cases that are adding on, there's a huge backlog of the previously untreated cases. This is one clinic of mine where multiple ages, all of them with Clubfoot. So they all could be treated with Ponsonby's method. So we then thought of the only way we can tackle this is using a public health model. And what is a public health model? A public health model identifies a problem, identifies the risk factors. In this case, the risk factor in this, in fact, we were discussing in the morning, there are known risk factors. One is a family history. So a child born with this may have a family history, so you need to understand that and take a history of that. The other only key thing that is there as the risk factor is smoking. If there is a family history and there is a smoking history during the first trimester, the risk to Clubfoot goes almost 20 times high in some of the papers. But otherwise, also there is a higher risk. So there is a genetic factor, there is an environmental factor. We now don't have the tools for genetic factor, but environmental factor certainly. There could be a campaign for that. So that needs to be looked. So identify the risk. The protective factor is early intervention, early treatment. So that is a protective factor that we have. So we needed to develop and evaluate interventions. What is the intervention? Is Ponsonby's method, which is scalable, which is non-surgical, with long-term good results. So the next step in public health is scaling up a good method. So you have 7 clinics, scale it up to 44. That's a clearly, is that all? No. Once you've scaled up, you need to evaluate again. What are the weaknesses and what are the strengths? And how do you bridge the gap between the weaknesses and the strengths? So that is a true public health method. So recognition of the problem, identifying risk factors, developing interventions, scaling up the interventions and re-evaluating. It's a constant journey. We need to continue to do that. Our program started in 2009, first in a private hospital. Then we realized poor patients don't go to private hospitals. They go only to the public hospitals. And they are referred to usually medical colleges because earlier the treatment was predominantly surgical. And we've all seen the poor results of the surgical as reported by the previous speakers. And Santosh has already mentioned, we started, the first was Government of Delhi. We were lucky. The Chief Minister had a problem earlier and she immediately wanted to scale it up for others. So we had the MOU, Memorandum of Understanding. Because if you want to work with the government, there has to be an MOU with the government, and therefore we worked with the government, hospitals. And what was the contribution that we did? Training of doctors, providing trained counselors, providing free braces to every child. So there was a debate. We give it to only the poor families. So that created a problem when it came to actual delivery. Why? Because then you needed to get some patients, they were in the borderline area, so they would cook up some certificates, no, we are in the BPL category, getting that. We didn't want people to fudge on the affordability. You give it free. You want to contribute to the program, maybe you could have a donation booth or whatever where you can contribute to a national health program, whatever. But we didn't want them to pay for it or fudge data on the affordability. We also wanted the cure people, their counselors to maintain records, manage a 24/7 helpline. So we did have, in fact, the 24/7 helpline was used by our people during the COVID pandemic to counsel so many of those children's families who had COVID. We also appointed a manager to manage a state level program. What was the government responsibility that we agreed on? Agree for a partnership, agree for a weekly clinic, commit doctors to the clinic, send doctors for training, there is a leave time for the training period, provide casting material, provide facility for tenotomy, and give space for the counselor. A table and chair to sit in, that's all that is required. But the important thing, as Santosh mentioned, is creating a program, not just training them and leaving alone. You need to get them to do the thing in a program manner, not just training them. So once we had 3 state programs on, then we decided, no, that is not. If you want to scale up, you need more doctors that are responsible for this, who know this method, and you can train others. So we had a national training program for key trainers, training of trainers. So we created those trainers and we created a curriculum which is a structured curriculum. So that there is uniformity of the program, there is benchmarking and quality in the training program. So every program they have to go through structured 12 lectures. 12 lectures every doctor goes through with hands-on on the model and on children. Only then they get the certificate. So that is what we have been doing. Dr. Nagropenny was quite there. You can see him in the picture here. He was very helpful in structuring. Many of the slides are his slide, which I showed today, because he was very generous in providing some of the teaching material for us. This was done in Lady Hardinge Medical College when we created the curriculum. And we still use the curriculum with additions and upgradations on recent advances that we have had. So unique part is the counselors. And that is a key component to maintain quality. Dr. Shafiq Pirani mentioned about importance of quality. You cannot have quality with the busy clinics that doctors have. For example, in my clinic, I get 80 to 100 children in one day. One day's clinic, 80 to 100. There's no way I can keep sense of what is on, keep track of what's going on. There has to be a counselor. So the counselors help parents understand the disease, the problem, the progress. Tell them about casting, tenotomy, and long-term bracing. All are equally important. The pamphlets are there, yes. As the number of cases increased and the bracing availability, many of them carried home visits and maintained the telephone lines. So all states have the state level contact number in their regional language. Kerala is Malayalam, in Maharashtra is Marathi. So in the regional language, yeah. As the number of cases increased, the brace problem was there. And in the COVID period, we had a tough time of supply chain logistics. So we had recycling of braces also being done. And all the braces that are used here, that you see here, are manufactured by persons with disabilities. So we're giving employment to them also and get them. So this is the way the public health model progressed. 2009-10, the number of red dots that you see are the clinics. 11-12 increased. 14 increased, that's 16, and that's today. There is a red dot in every state of India where we have a clinic. So that is the importance of scaling up. But then we also realized we need to have awareness programs. So we had a brand ambassador, John Abraham. He agreed very generously, media programs on this. And of course, the Global Clubfoot program was also to get interaction with the global experts. Global experts are also the local administrators in this whole program. We had a marathon run to tell parents that your child, if treated for Clubfoot, can also participate in a marathon. And of course, the President, Ramnath Kovindji, Honorable, He was very generous to be there. And the moment he saw these kids, he said, I want a picture with all these children. So all these children that are there have been treated for Clubfoot. He was really excited when he saw that the health minister, the health secretary, all were there. And we have a football team that creates awareness both for the parents and for the others that these children can also play like normal children. It's a football team. They participate in a football league, and that's a full match that they have. That's our cure team that we have. All treated children for Clubfoot, normal foot, playing football. And football is a real challenging game. So creating partnership is important. Goal is no more disability. But if you see this graph on the variety of disabilities, there are so many of them. So can we extrapolate this to other areas? Reaching out to Clubfoot children, we have done Ponseti's method. Kerala has a population of 35 million. Almost 2 per 1,000 is their incidence. So 1,000 new babies born every year. The key components could be early recognition, early access to treatment, early Ponseti treatment, ensuring brace protocol for 5 years. So counselors are important. Ensuring follow-up and early recognition, counselors again are important. Management of relapse, doctors need to be trained for that. So capacity building at all levels, from peripheral to the central. Training of PHC doctors, very important, training of pediatricians and obstetricians, so that they refer at the right time, so they know that this is the best method of treatment. And training of doctors along with mentorship. We recognize the need for mentorship. That's expensive, but if there is a statewide program on this, busy clinics, they can have doctors coming from less busy clinics to spend a few time to manage problems, complications and other issues. So we need to have record keeping with programming evaluation possible with this kind of a software. With this will help us geographically mapping areas and then finding out where the problems are, where solutions can be found, including if there are more cases of syndromic children in one area, what are the reasons, maybe it needs genetic evaluation, whatever needs to be done. And creating referral systems, that's part of this. So referral systems particularly for syndromic children. And the key important component would be quality assurance at all levels. You know, to create key performance indicators and quality assurance at every level. Antenatal counseling, very important, and counseling for follow-up. Vision, I would say, spina bifida is an important part of your disability from Clubfoot, which is happening. Can be preconception, folic acid should be a huge campaign. Green leafy vegetables and folic acid, you can push both or one. Genetic counseling for syndromic children and access to genetic evaluation, both are important. There is a need to scale up for other birth defects. It's possible, doable. We may not have an intervention for all of them, but whatever best is possible to get the optimum level of functioning, physical and intellectual, should be done for them. It is possible to evolve a successful national and state program publicly partnering with the public hospitals. It's important that we create a program and not just train doctors. So let us all work towards Kerala free from disability caused by Clubfoot and in the future from other birth defects. Thank you. Questions?
May I now invite Ms. Roslyn Owen, Executive Director, Global Health Food Initiative, London, to deliver the plenary talk on Clubfoot management.
Thank you so much. I'm so honored to be with you today. If you just give me a minute, I will share my slides. If you could enable that, please. Thank you. Sorry, I just need you to allow my screen sharing so that I can share my slides, please.
We can share
Okay,
now, ma'am.
I got it. Thank you. Fantastic. Thank you so much. Good afternoon, good evening to everyone. Good morning to some internationally as well, I know. Honorable Chief Minister, Honorable Health Minister, Dr. Rajan, Dr. Purani, Dr. Penny, Dr. Matthew Varghese, Dr. Santosh, and all of the assembled experts and organizers. I just thank you so much for including me in this such an exciting and important program today. I'm really honored to be part of it and to be able to share some thoughts as well. My name is Rosalind Owen. I'm the Executive Director of Global Clubfoot Initiative, which is a network of more than 35 organizations working together and supporting the treatment of over 30,000 new children born with clubfoot each year around the world, with a main focus on the low and middle income countries. I'm also a physiotherapist specializing in clubfoot treatment. Here in London, I work at the Chelsea and Westminster Hospital once a week, and it's one of the highlights of my week to go and meet the babies and their families and to provide treatment. I wish I was there in person with all of you today. India has a really special part in my heart and also in my journey in global health. When I was 19 years old, I spent a year working in a rural mission hospital in Tamil Nadu, in a village called Ambalakai, near Odhanchatram, which we always called ODC, as even the locals found it quite a mouthful to pronounce. And working there, I met a couple, the Cherians, both of whom were doctors. After they had gotten married, they moved to the area from Kerala and spent the rest of their lives serving the poor and disadvantaged. Their lives of humble dedication and service inspired me and continue to do so. Then in 2017, I had the great privilege of visiting again as part of the Global Clubfoot Conference, organized by CIIT. That was a fantastic time of learning together, and I was so impressed to witness how you have all built this incredible countrywide program treating thousands of children each year, and a real example to the rest of the world. So we know that every 3 minutes, a child with clubfoot is born across the world. However, like Dr. Santosh, it wasn't until 2008, when I went to work in Malawi, that I first met a child with clubfoot. Here in the UK, although we have a similar incidence of clubfoot, around 1 in 800, it is treated at birth, and so it's not visible in the population, and awareness is very low. When I ask people what they know about clubfoot, most people say they think it's something that occurred many years ago, but they don't seem to see it today. That's because babies with clubfoot are treated at birth. It wasn't so in Malawi, that was for sure. We used to say, eat a big breakfast on Clubfoot Clinic Day, because when we arrived at the clinic, there would already be a line of families out of the door. They'd traveled from all over the country, and they would line up at the door of the hospital waiting until we began the clinic, where we would soak and unwind the casts, manipulate and stretch the little feet, fit braces, counsel the parents, and support the families. Every week I was amazed. It seemed like a miracle when the casts were removed and these tiny curled up feet became so beautifully straight in just a matter of weeks. It still amazes me today. I think it's absolutely incredible that such a dramatic and effective change in the foot position can be achieved with such minimal surgery. It is so simple in some ways, but as Dr. Matthew described, it must be done with exacting precision. During this time, I started to learn and hear about pioneering programs in other parts of the world too. In Uganda with Drs. Purani and Penny, Bangladesh, India, it was spreading around the globe. And as Dr. Matthew mentioned with the public health model, we realized that this could be and was being done on a countrywide scale. And this led us to think, if it could be implemented in every country, then why not globally? That was the vision that Global Clubfoot Initiative started with, and it's what we've been working to ever since. So let's take a look at the scale of the challenge. Clubfoot occurs in around 1 in 800 births worldwide. That means there's around 175,000 children born with the condition every year. And when we look at the birth data, we find that more than 90% of cases are born in low and middle income countries. Without treatment, there's huge pain, impairment, and stigma, as this middle picture shows. But with Ponseti treatment, there's more than a 90% success rate in the corrective phase. As you can see there on the right, a boy born in Bangladesh playing football. Global Clubfoot Initiative exists to bring people and organizations together to work towards the vision that all children born with clubfoot can and should be able to access high quality and effective treatment. We're a network made up of more than 35 mostly non-governmental organizations, ranging from the very large, such as ICRC, CBM International, Humanity and Inclusion, to smaller local NGOs at the country level. And they all have an equal voice within the network. Our member organizations cover more than 50 countries and support the treatment of around 30,000 children born with clubfoot every year. GCI does not itself support service delivery, but we work through three main parts of work: advocacy, collaboration, and training and education to advance the mission that we share with our members and many others worldwide. So, as I mentioned, we have three main areas that we work across. Advocacy is amplifying the voices of those who are calling for clubfoot treatment. We want their voices to be heard at a higher and higher level so that we can influence change. We have a very strong training program that's being rolled out in many countries around the world and is very well received. But the one that I want to talk about today is probably the one we talk about least. That's collaboration. Why don't we talk about collaboration? Well, it has been said of collaboration that if you don't have to do it, then don't. And as someone who's worked in collaboration for the last 10 years, I would say I agree with it, with that statement. Collaboration can be difficult, can be time-consuming, it can be costly. It means being prepared to learn from others, let go of our own preferences sometimes. Oftentimes we have to let others take the lead to find consensus, to work towards the goal that we share. But in some cases, collaboration is necessary. So why would we do it, and why should I talk about it today? Well, when we have a big, complex challenge in front of us, a big problem to solve, a big, audacious goal, such as ensuring that all children born with clubfoot get treatment, it is more than one person or organization can achieve on their own. We've got to work together. When we started the conversations that Global Clubfoot Initiative was born out of, and Dr. Penny was there in London in 2009, along with many others, we looked at what had been achieved globally so far. It was very early days still. Ponseti treatment was just starting to be implemented widely. Those organizations that had already worked together in several countries said in these meetings, you know, when we worked together, we actually found we could achieve more. We each have different strengths and perspectives, but we share this huge, audacious goal. Let's create a way to work together. And that was why Global Clubfoot Initiative was started. Later, in 2017, we came together with our members to work out what it would really take to address this on a global scale. and came up with our global strategy, Run Free 2030. One thing that really struck me as we worked on this and as we gathered information on the costs of treatment around the world was just the huge return on investment that can be gained with treating clubfoot. The information that we got from around the world showed that it cost between $150 to $500 per child for the entire course of treatment, depending on the country. But the return on that over the course of a lifetime was huge in terms of the economic contribution the child would later be able to make to society, a more than 200 times return on investment. Tell that to any investor, and I'm sure they will be very excited. And it is really exciting. And the benefits are far more than economic. For each and every one of those children, this is a truly life-changing opportunity. I remember reading some research that was conducted with older children living with untreated clubfoot in Malawi. The researchers interviewed the children to find out what their experience of life was like. And they found that they were living with pain, exclusion, and indignity, all for want of a simple treatment applied early. The thing that touched me most was that when they asked what they wanted, these children said that the thing that they most wanted was to be able to ride a bike. Such a simple goal, but so meaningful. The gift of mobility, to be able to move fast and free. So life-changing to be able to go to school, play with one's friends, and run free. As part of Run Free 2030, we put together this model for implementation of comprehensive clubfoot care, and I believe that every aspect of this model has been discussed today. The challenge really is that each of these steps must be present for every child. Otherwise, the whole treatment falls down. You can have a clinic, but if there's no access, it won't work. You can treat a child, but if they don't adhere to the bracing process for 4 to 5 years, the likelihood is that the foot position will relapse. You can have a whole program in place, ready to go, but if the birth attendants don't know what clubfoot is and that it can be treated and don't make the referral, then that child will get missed. Putting all of these steps in place is certainly possible, and we've seen that in countries around the world, but it's not easy. It cuts across disciplines and requires a multidisciplinary input, and that's why collaboration is needed in clubfoot care. From awareness to identification and referral, access to a clubfoot clinic which has capacity, well-trained clinicians and resources, to the treatment itself. And we know it's not just a one-off treatment. It requires years of dedication and commitment from the whole team. And when I talk about the team, I fully include the child's family in that. They must and are partners in the treatment. If we think for a minute about the World Health Organization and which part of their departments this would fall under, clubfoot treatment cuts across many: maternal and child health, surgery, rehabilitation, assistive technology, to name just a few, and that is why collaboration is needed. Clubfoot is not going away. We know that every 3 minutes another child is born, and so far we don't know how to prevent it. So we do need strong systems in place for each of these areas that are embedded within country health systems. I'm so happy today to see the strong leadership from the Ministry of Health in Kerala. For GCI, as a network mainly made up of NGOs, we fully recognize and advocate that in order to provide comprehensive clubfoot care and bring all those elements needed together, that this needs to be led by government. Today, you're taking the lead on this in Kerala. I applaud this, and I hope that many other countries will follow. Our goal is very big: to bring all of these steps to every child in the world born with clubfoot. That is why collaboration is needed. Now, because a picture speaks 1,000 words, I've got a picture of each of these aspects just to quickly run through. So awareness, here are a group of people in Bangladesh marching on World Clubfoot Day to raise awareness about clubfoot and the treatment. Identification and referral. I've heard many speak about this today. So important that it's identified early and the correct referral is made. Clubfoot clinic and access. It's no use having a clubfoot clinic if people can't get to it. And I heard you talking very strategically about that today, about where the clinics will be situated in Kerala so that people can reach them. This is a clinic in Uganda. Many, many children have come along to this with their families, and still many more are needed. Then there needs to be capacity, training, and resources. We've seen the Africa Clubfoot Training, or ACT, make a huge difference in this area over the last few years, as clinicians have been trained and train the trainer programs implemented in many countries, thereby increasing countries' own capacity for ongoing training, which is what is really needed. And it's not just training, it's supervision, it's mentoring, it's working together, it's collaboration. Then the steps of treatment itself. In the corrective phase of treatment, we have the manipulation and casting, the tenotomy, which frees up the Achilles tendon, and the foot abduction bracing phase. All of them equally important and essential to the success of the treatment. Once children go into the brace, we really have to hand it over to the families to carry on the treatment at home. We have to build a partnership with them where we can trust them to do that and where they can trust us that they can approach us with any difficulties they're having. I love the model that you have there in India of using counselors in the clinics to support parents with this treatment journey. And as a clinician myself, I wish that we could have some of your counselors come and work with us in our clinic in London. So valuable to be able to spend that time with the families and share the journey with them. So that's the comprehensive clubfoot care model. And you might ask, has there been any progress since we started over a decade ago? Well, I'm very happy to report that there absolutely has. There's been huge progress over the years as the Ponseti treatment has spread, as this graph shows. And by the way, this is not a cumulative graph. This is new cases starting treatment. At Global Clubfoot Initiative, we do a survey every 2 years to measure the treatment and progress. In the time period that this study and this graph covers, that's around 250,000 children that have been treated in some of the most challenging environments who are now able to walk, run, play, and go to school with their friends. Half of them probably don't even remember they ever even had a foot difference or that they went through treatment. Despite the huge progress, the 32,000 children that are currently enrolled for treatment each year still represents less than 20% of all children born in low and middle income countries with clubfoot. That's 1 in 5 that actually get treatment. That number reminds me of this group of children that I met in Ethiopia. We traveled a long way across the mountainous plains by car. And when we arrived at this village, the health worker noticed a group of children playing. They ran up to the car and they told them, "Go and get that girl that was born with clubfoot." A few minutes later, a group of children ran towards us. I knew that one of them was the child who'd been treated, but I couldn't see which one. Now, playing out with her friends, neither she nor they could see any difference in her ability to be part of that. And if you're wondering which child it was, it's the little girl in the orange trousers. This girl was lucky. She lives in a very remote area, but someone found her and told her parents that treatment was available. I spoke with many other mothers in Ethiopia, and sadly, this is a story that I hear repeated from all over the world. They told me that when their babies were born, they were told to take them home and care for them as best they could, as nothing could be done for their feet. We need to change this. It shouldn't be a matter of luck or even parental dedication. It should be the right of every child to get treatment. The graph I showed showing progress contains data in a most recent survey round from 60 countries. And we collect that data every 2 years. Every time we do our global survey, more countries report providing Ponseti treatment. The 60 countries included in the most recent collection round contain more than 70% of all children born with clubfoot. If we could get to 100% of children in just those 60 countries, it would be incredible. However, treatment coverage within many of those countries remains low. It's less than 25% in most. And what we've come to understand is that in order for coverage to increase, the demand for treatment needs to increase. That is, families of children with clubfoot need to know about it, need to seek treatment out, or even demand it. At the same time, the supply of treatment needs to increase so that treatment is both available and accessible. The two things need to increase simultaneously, and this we've seen is a really delicate process of balancing one out against the other, of incremental gains, of slowly building and working towards that coverage. And I'm so happy to hear of your plans today to increase both demand and supply in Kerala, and how you're being really strategic about this. Collaboration is surely needed in a process like this. I'm showing this picture again because I met this mother and her baby with clubfoot many years ago in Ethiopia. We'd been working in the clinic all morning. Everyone was hungry. We were just about to close the clinic for the day and go and have some lunch. And this family arrived. And they got there late because they'd been walking all night long across the mountains just to have this baby's cast changed. This mother's dedication and commitment were incredible. And I was so happy for them that they arrived before the clinic closed and that treatment was available to them. But it shouldn't be like that. Every child born with clubfoot has a right to this simple and highly effective treatment. Now, the comprehensive clubfoot care model that I outlined earlier must continue with a steady focus on the child, the needs of the child and their family, and must be underpinned by quality and sustainability. Initiatives like the one Dr. Pirani mentioned with the data capture and measurement are so important, as are initiatives like the counsellors in the clinic to ensure quality treatment, as is training and ongoing mentoring. Then working in partnership, as mentioned by Dr. Santosh and many others, brings sustainability, putting the systems in place, putting the pathways in place, working with the government of the country. Collaboration is not easy, but we must do it for the child in front of us, for their family, and for the 1.5 million children that will be born with clubfoot in the next decade. Like this little boy who was treated for clubfoot in Uganda, we need to keep marching towards our goal. I believe that the work that is being started here today, the collaboration between NGOs and government, between different sectors and departments within the health and social care systems, between clinicians, community health workers, and children's families will provide a model that many will follow. This incredibly powerful picture shows parents who are both affected with Clubfoot. They weren't able to get treatment, but their child was. How incredible that this child will walk and run free from disability due to this simple treatment. I was recently in a webinar with Dr. Aisha Da Costa of the World Health Organization Maternal and Child Health Department. She outlined that one of the main challenges that they're currently facing is that there's a pervasive myth that congenital birth differences are considered to be not to be treatable. That when people think about them, they think, oh, it's too complex, there's nothing that can be done. She asked for models of success and to show examples of where this is being done successfully. Today, I believe that with the type of leadership shown today by the Kerala Clubfoot program, that not only can we create such a model of success, but that this can be scaled globally, then extended to children with other conditions too. That by putting those systems and pathways in place for comprehensive Clubfoot care, we can build systems that are both scalable and reproducible. There are challenges ahead, but I truly believe that when we work together, as demonstrated so brilliantly by the partners involved in this initiative today, we can end the disability caused by Clubfoot through comprehensive provision of Clubfoot care. Thank you so much for having me. And if you have any questions, please feel free. Thank you.
Thank you, ma'am. So with that, to the final part of this session, the roundtable on Clubfoot management, the way forward. We are honored and privileged to have experts from all parts of the world to participate in this roundtable. We have already met Dr. Santosh George and Dr. Matthew Verghese from Cure India and Dr. Shafiq Kirani too. So with the limited time we have, let me give a brief introduction to our other guests. We have Dr. Norgo Penny. Dr. Penny is a clinical professor, University of British Columbia, Canada. He has had a long-term interest in international orthopedics. Early in his career, he did several voluntary assignments in Africa. With his family, he then lived and worked full-time for 6 years in Uganda, setting up a countrywide children's orthopedic rehabilitation program. He has been an advisor to WHO's Disability and Rehabilitation Team. He has a research collaboration with the International Center for Evidence on Disability at the London School of Hygiene and Tropical Medicine. We have Dr. Ahmed Hassan, who serves as Director of Operations for the Little Feet Club, a non-profit organization dedicated to helping scale Clubfoot treatment initiatives. He holds a master's degree in health informatics from the University of Michigan and is currently preparing to begin a career as an orthopedic surgery resident. Dr. Vikas Gupta is the professor, Central Institute of Orthopedics, BMMSC, and Safdarjung Hospital, New Delhi. Dr. Gupta did his MS from BMMC and Safdarjung Medical College, and then subsequently did his fellowship at DKCH Hospital. His unit, in partnership with Cure India, is managing children presenting with Clubfoot of all ages for the almost past 12 years. We have Dr. Venkateshan Sambat Kumar. He is Associate Professor, Department of Orthopedics at All India Institute of Medical Sciences, New Delhi. Dr. Babu George is the Director of Child Development Center, Medical College, Thiruvananthapuram. He has an experience of over 30 years in academics and clinical arena. His work mainly focuses on developmental and behavioral pediatrics. I am very happy to welcome our moderator, Dr. Zulfikar Ahmed. Sir is the first pediatric cardiologist in Kerala. He is currently the clinical professor of pediatrics and Adolescent Cardiology, Child Development Center, Kerala. He is a former professor and head Pediatric Cardiology, Government Medical College, and is a former chairperson of National IAP Cardiology Chapter. Over to you, sir.
Mic and we have mic. I think many of good evening, and I think many of us have probably noticed Ms. Rosaline becoming a bit emotional during the talk, and the commitment, the passion we see. So this is a international conference on Clubfoot, what we call as a trans-oceanic conversation, because we have people from Canada, we have people from UK, everywhere. And this was basically organized with the support of this particular organization. And we have a very strong political will, as we have seen in the morning, and also executive will also. And the participants in the academic concert in the morning was basically by a pediatric geneticist, orthopedicians, dedicated Ponseti orthopedic people, pathfinders like Dr. Matthew, and disability experts like Babu, and administrators. And we had faculty from not only from India, Canada, US, and UK. Last one was from UK. And the participants included postgraduates, field functionaries, nurses, paramedical staff, and doctors. And at the end of the day, we end up with a high note with a round table, and you can possibly see Mohandas Karamchand Gandhi in the first round table in UK. And I think that's also very relevant to this, because we are going to reach to the poorest of poor or whatever. And the Ponseti method is by Ignacio Ponseti, for people who are not aware of this. He basically is a Spanish American who was a son of a watchmaker, later became a medical person, a faculty of Iowa, and he also got involved in the Spanish Civil War, which was basically a very ugly war. You all know that. And Ponseti method is basic. We have all learned that it's a strong physiological background. It's painless, fast, cost-effective, and successful across continents. That is perhaps the most important part of all. And this is a structured, sequential, up to 4 years it takes, and follow up with a small surgical component like tenotomy. And this I knew only yesterday, that the World Clubfoot Day was introduced in 2013, basically because it was Ponseti's birthday on June 3rd. Maybe next time we will have the meeting on June 3rd, post-COVID. And this, I think, another practical point we should remember is that it is innovative, non-surgical, effective, practiced across 130 countries, either to the west or the east, or all kind of economies, market economies, emerging market economies like India, or what you call as a middle and low income countries like others. And Liz has already introduced the participants of the round table. And because Dr. Babu George is the host of this particular summit, I would like to ask some questions to him. Your center has done some excellent field studies, I remember, from Alappuzha, childhood disability. So what is the prevalence and influence of Clubfoot on pediatric disability?
And the opening batsman. Actually, CDC did community studies, especially throughout state we have done community studies. And it was basically through ICDS system. And it was found that in Kerala, throughout, if you take childhood disability or development delay status, it is from 2 to 4%. And actually, in some pockets it is 4, some is 2. Around, we can say that it is somewhere around 3.
2 to 3%.
And it was done through a simple screening method our Trivandrum screening chart, in which we can identify whether a child is having development delay or not. It is a highly validated tool, and these children may go on to future disability. That is one thing. Now, ICDS Pattanakad, that is in near Alappuzha, we did a study and found that it is same, almost 1 to 2 cases. That Clubfoot, 1 to 2 cases per around 1,000 cases. Same. But the important thing is that if you can identify these development delay early, intervention, that is the thing. Especially in newborn babies, we can give early stimulation. It has proved that early stimulation will improve the future disability, impending disability. Very important. We have to follow these children at least till 5 years. That is very important because
that happens to be almost the same period where you are managing Clubfoot also. No?
It was proved, through many studies. It was proved in Kerala also. It was proved that early intervention, early stimulation will give maximum benefit for the baby and for the family.
Now, I think you are started with as a pediatrician turned disability expert and now an administrator. How long have you been familiar with this Ponseti treatment? Because is it a recent acquaintance with the Ponseti?
That's a tricky question.
Because I was also introduced to this Ponseti method a few weeks ago, maybe.
While we were studying MBBS and PG, actually pediatric surgeons were doing these cases. We used to refer to pediatric surgery. But over a period of time, it was that orthopedician actually became the center of attraction and control and all. Then by 10 years back, this Clubfoot clinic was set up in Medical College, Trivandrum. At that time, we had some idea regarding something is going on, that's all. But 3 years back, we met Santosh, and then we came to know regarding the importance of Ponseti. And
so Santosh was the bridge between Kerala and Ponseti.
And if you can popularize, in future Ponseti will be asked as a short note or as a long question for pediatricians and
your institution also plays a very significant role recently, of late, in high-risk pregnancy and fetal anomalies. So, can you brief us on data on Clubfoot till now? I mean, because it is a recent phenomenon, but still, from whatever data you got,
okay. Actually, for the first time in government sector, with support of our CDC chairman Dajan sir, a project was started named Sarda project, and it was. The aim is to start a fetal medicine unit in the future. That was the main aim. And luckily we got a fetal medicine expert who was trained in fetal medicine and perinatology, and he joined our center. And over the last 1 year, he has been seeing some 600 cases. But it is not a community prevalence. What I am going to say,
because it's a high-risk baby.
It is a high-risk baby. And actually, for the last 1 year, we saw 600 cases. And he was telling that he could see 15 Clubfoot cases. 15. 1-5. And in that, 13 were some syndrome-oriented and 2 isolated. And unilateral, bilateral distribution was same, almost 8 or 7 or something like that. And his that agreement with the outcome was 100%. Because we followed these cases.
Later,
and if we say before 20 weeks there is one Clubfoot, after delivery there will be 100% agreement was there. And on follow-up, out of 15 cases, 7 cases opted for MTP. Maybe most of that syndrome oriented opted for MTP. And then the only thing which when we follow up, what we get data is that last time our fetal medicine expert was saying that by 4 by around 4 months, child became okay. Physically, phenotypically, child was okay. Then parents will say that it is okay. They are that missing that follow-up. That is the only thing. That there is a role for pediatrician for this continued support,
follow-up and
follow-up
insisting
that is the
on
only
this.
thing. Then in that cases, he around 600 cases he could see 22 neural tube defects. That is another thing. And as pediatricians, we know that there is a book known as Smith's that recognizable syndromes.
Recognizable.
Out of this cases, we have seen almost all cases, all pictures seen in that book. That means plenty of cases are there, but many cases get natural abortion or maybe MTP will be done and all. That means there is a role for prevention of this neural tube defects. That is the thing. Either that food fortification, that's not here, or that dietary modification or peri-conceptual folic acid. If many studies have, there are papers which say that only 10 to 50% of mothers know that they have to take folic acid during the peri-conception period. And in countries where this folic acid was given as a mandatory requirement, 50% of these disabilities were prevented.
Overall.
50%. That is, there is documented evidence and papers are there. If that means WHO recommendation is also there. When a woman plan for this pregnancy, she has to start immediately and has to continue till 12 weeks. 12 weeks. But usually we are giving IFA after delivery. So after that pregnancy.
That is confirmed.
That means if Kerala can start this, Kerala will be the first state in India which follow this thing. Because it is documented that 50% of disability due to the folic acid deficiency can be prevented. And it is very cost-effective thing also because very cheap. And also we can give dietary modification or anything. As sir already told, any sort of mother or combination can be done. That is the thing which I can.
Thank you, Dr. Babu. I think we will go to Delhi. Dr. Vikas Gupta. Sir, good evening.
Yeah, good evening. Good evening.
Yeah.
I'm audible?
Yeah, very much audible. And I'm basically a pediatrician turned pediatric cardiologist. So I would like to ask you, over many decades, what are the striking changes which has happened in the practice of treating clubfoot in infants?
Yeah, thank you, sir. At the outset, I would like to thank CIT and the Kerala government for inviting me. And I must congratulate Kerala government for taking this noble initiative. And I hope the other states would also take the lead. So before I answer this question, let me share with you how I got interested into clubfoot. Probably this would answer this question also. So actually, when I joined MS Orthopedics way back in 1990, I was posted in clubfoot clinic by my consultants. And my duty was to apply cast in a manner practiced those days, as if I would be trying to straighten the bent wire with pressure over the lateral midfoot. And as expected, as we all know, those foot never got fully corrected. And as a result, my professors those days enjoying doing extensive surgeries. And it was very painful to see that even after surgery, the results were not good. In fact, it actually worsened. And I was in a dilemma. It was very painful that could something be done in a better way. And to tell you that truly that when my daughter was born in 1996, the first thing I looked was her feet. I wanted to rule out the clubfoot, which was actually untreatable those days. So it's only after reading Dr. Ponsetti's book in 1999 that I started applying cast in a way we practice today, with some apprehension for tenotomy in those initial years. And the results were so fantastic. It was beyond my imagination. And then, the rest is history. Then I attended courses by stalwarts like Dr. Shafiq Pirani and Dr. Penny. And since then, there has been no looking back. So to tell you that I'm still in charge of that clinic, from the success rate of 10 to 20%, now it's almost 90 to 95%, especially in typical Clubfoot. And I think I don't remember when I did extensive soft tissue surgery for Clubfoot in recent past. So I think there has been a shift, almost 360-degree shift in the way we practice Clubfoot these days. And the Ponseti has made a difference. Thank you. That's all I want to say here.
Thank you, sir. I think you have been very illustrative. And now I think will you be able to offer a comparative assessment of the what we consider as old kite method and Ponseti method primarily, because you have anyway highlighted on the problems of surgery. So why Ponseti is preferred over the kite method?
Actually, the kite method, I would say, it's not scientific at all. It's not based on the pathoanatomy and the kinematics of the foot, which we have now understood. The kites method actually involved correcting the correcting the clubfoot by giving a counter pressure at the calcaneum-cuboid joint, which actually blocks the movement of the calcaneum. So in the Ponseti method, we actually want calcaneum to move, but it's called calcaneopedis block around the teller head. So I think the kites method, that was the reason actually the kites method failed. In fact, the patients, the children were given weekly casts for even months, even extending up to years. And in spite of that, the foot never got corrected. So I think we cannot compare oranges with apples. So it is something I think I actually really surprised how we were managing fees those days. And with Ponseti, there has been it's a highly efficient method, and the parents are very happy. And those days with the kites method, the only outcome was surgery after a few months of casting.
Trial.
And that too with a poor outcome.
And
I hope.
yeah, I think it's very clear. And this is a little more of a personal question. You are an academician, a teacher, of course, and a very important pediatric orthopedic surgeon. So tell us something about your, let's say, at least more than a decade of partnership with Cure India. How has it been?
Yeah, I
satisfying?
think the way we are going, it would not have been possible without Cure International. So before we partnered with Cure, we were missing on follow-ups. There was very poor data recording, and there was difficulty in getting right brace. And since almost for last 12 years, there has been dramatic improvement in our record keeping, which has helped us in publishing helped us in publication as well as presentation. Moreover, the presence of counselor makes a great difference. As discussed by Dr. Matthews also, that in a busy OPD clinic, we are unable to give enough time to the parents. And in fact, most of my parents now directly go to the counselors first before coming to me, because they can have a heart-to-heart talk with the counselors, which they fail to do with us. With the presence of Cure India, now they have shared our responsibility. Almost they have shared the load which we were having initially. So in terms of record keeping, brace, follow-up, and helping us out in our busy day-to-day clinic. So I think it has been a tremendous partnership, and it has definitely made a difference in our results.
And to the children also, naturally, children of India.
Definitely, children, yeah.
And now we have Dr. Venkatesh Sambat Kumar from Delhi. Good evening, sir.
Good evening, sir. Can you hear me, sir?
Greetings from Kerala.
Thank you very much. Thank you. I would like to thank all the organizers, including Cure India, the government of Kerala, for giving me this opportunity to participate in this program. I wish all the success for the entire state of Kerala and its team.
Yeah. I'm planning to ask you a little tricky question, a very practical question, I suppose. In Kerala, over the years, when I was a postgraduate in pediatrics and all, especially we have seen orthopedic surgeons taking over the management of Clubfoot from pediatric surgeons in Kerala over the last 3 decades. So has this kind of phenomenon happened in Delhi, or it was from the beginning itself, it was the orthopedicians' territory?
So at least in the hospital which I'm working in at All India Institute of Medical Sciences in New Delhi, we have been running the Clubfoot program ever since I have been in this hospital since 2009.
I see.
So from then on. So it has always used to be the orthopedicians who treat these patients, mainly because pediatric surgery at AIIMS is a secondary referral clinic. Only patients who are screened in the general surgery OPD get referred there. Whereas orthopedics is a primary clinic. So the moment a child comes with an orthopedic problem, they will be referred to the orthopedicians, and only selected referrals go to the pediatric surgery. I believe at most hospitals in Delhi, the story is pretty much the same. It is the orthopedicians who have been treating these patients for a long, long time in Delhi.
That is right. And apart from the Achilles tendon tenotomy, which is, I suppose, it is a standard procedure for Ponseti, how many of your kids for the last 12 years on Ponseti required additional surgery?
Okay. So here I would like to classify as surgeries which have been advocated in the Ponseti technique, like, for example, tibialis anterior tendon transfer for a dynamic supination deformity. So that's pretty much part of the Ponseti protocol as well, which we have been routinely doing in around 10% of our patients who follow the protocol. But apart from that, there are certain surgeries which we had to do occasionally. For example, we have patients who come with forefoot recurrence in sometimes where we find the plantar fascia to be tight, and which is causing the first metatarsal to drop and forefoot to adduct. In those cases, where along with the tenotomy, we also do a plantar fascia release, which is like a modified stainless kind of a release, which we do. And in certain patients, especially children who have got syndromes associated with them, say, for example, arthrogryposis multiplex congenita and other syndromes where they have a very stiff foot, there are certain additional procedures sometimes which are required. Of course, I understand that AMC is a condition where surgery is not going to give good outcomes, but there are other conditions like late presenting cases where we still do some soft tissue releases, but the rates have come down drastically. So hardly maybe like 5% of our patients would require any kind of these surgeries.
I think that again is an indication of our turning to Ponseti method.
Yes, sir.
And again, yes, that is also another related thing. That is a late entry of children into this management. What is your because see, AIIMS basically has a drainage, huge, vast drainage area from North India, like PGA or AIIMS drain part of North India. So, do you encounter many late entries into management?
Yes, of course, we encounter late entries a lot of times, not only because we have a large catchment area, but also because we treat that part of the socioeconomic strata where people tend to leave the problems unattended until it gets big. Say, for example, for people from the poor socioeconomic
there is a connection problem. Yeah. Yeah. Please.
We had advocated Ponseti in late Clubfoot as well. So even in late presenters, we are using Ponseti method.
Okay. So even that is good. Now we come to the great man himself, Norgrave Penny. Good morning, sir. I think it must be good early morning in Canada. Good morning.
Good morning.
Yeah, from everybody,
in
the audience and also people listening to you. So, would you like to share your presentation now, so that after that I can ask you a few questions or doubts? Whatever
okay,
you say.
I'll be sharing the screen. I hope you can all hear me and see me.
Yeah, definitely, sir.
Good. and that you were sharing at this point. Firstly, thank you so much for having me on this committee. Thank you to the organizing committee, the government of Kerala, and all of you. And it's so great to be here and to see some familiar faces and people I've worked with over the years. And to congratulate you in Kerala, I'm sorry, my pronunciation, Kerala, for all the work you've done with over the years with Clubfoot. Here we are at 10 years. I'm delighted to be here and to share a little bit with you. So let me go to full screen here, if I can get that there. There we are, that's a bit better. So I've had the real privilege of being able to come to India over more than a decade on numerous occasions. And here was just one particular meeting that we had developing the curriculum that's now used all over India. I can see some of my friends there, like Dr. Vikas Gupta and Dr. Matthew. Now, Santosh would be somewhere in the background. And it's been such a privilege to be involved with this from the beginning. And to have been, with you in Thiruvananthapuram in 2016 as we did this particular workshop. So, I've been in your part of the world, and it was a very wonderful memory for me as Santosh took me all around India to many different states, and I could see what was happening on the ground, doing some teaching in our sessions, seeing some of the children and evaluating them. These are all very wonderful memories for me. And I had the opportunity to put my feet into the Indian Ocean, and it was just terrific to see your part of the world. And if I wanted to talk to you just for a moment, I know you've had a lot of discussion already, but this is what I'd like to kind of just highlight for you. And that is, how do we convert the vertical to the horizontal? As Dr. Pirani will have told you, and Shafiq, if you're there in the background, I greet you too. It's terrific to see you online. There we are in the very early days of starting the Ponseti method in Africa, in Uganda. And this was a huge experience for the two of us, I think, as we tried to grapple with the issue of how do you implement this technique in an underdeveloped country. It then evolved into the Uganda Sustainable Clubfoot Care Project. And one of the problems we're dealing with right at the beginning is, how do we reach the poorest of the poor? How do we reach those that are way outside the main centers? And so we developed a public health approach to this, and this whole treatment paradigm, this whole treatment pathway to try and reach all of these children in remote communities. And it was a very extensive project, and I think led the way in terms of the idea of a national program. This is now this is almost 20 years in the making at this point. Well, once that became successful, the idea was, well, could this be done anywhere in the world? And this is just 20 country national Clubfoot projects that were started over the next few years in order to see, does it work everywhere? What are the ingredients that make for successful Clubfoot programming? And now you've heard from Roz Owen, who has headed up the Global Clubfoot Initiative, and she published, or we published together, this collaborative public health approach to Clubfoot intervention in 10 low and middle income countries, and looked over 2 years at the lessons learned and tried to modify things. At that time, there were 7,700 babies in 10 country programs included in that study, and it was published. And then a few years ago, Roz again and her group published, well, what's the results and what's the global perspective now? Clubfoot treatment in 2015, the global perspective. And at that time, there were 30 countries that were evaluated that now had national programs. And we saw that the coverage was still only less than 25%. So despite this huge amount of effort to get national programs going, we still weren't reaching all the children, especially the most remote. And this is a very challenging thought. And so how do we convert this a treatment program that we've introduced primarily in the medical colleges to the orthopedic experts? How do we convert this now to being more national, or in your situation, state-wise? Your particular state of Kerala is about the same population as Canada, interestingly enough. So it's a huge number of people and at least 600 babies a year that need to be reached. Well, it's by really extending the reach into the paramedical and social support sectors of your society, and also to the community and the caregivers. And that's how it becomes, the Clubfoot treatment program now becomes much more horizontal rather than a vertical treatment within a major center. And you are doing as well as anywhere I know on planet Earth, actually, in your state. And it has a lot of credit to the government of India, firstly, and then of the state, to have made this such a priority and to have sponsored and helped with programs, comprehensive programs, and you see all the people that have contributed. And then also the Cure Clubfoot India Trust, support of these wonderful ladies who are the counselors, moving the treatment program out into the community and to the individuals. And I think this has been such a key to the success, not just in your state, but all over India. That is, I find, inspirational. The whole Clubfoot treatment programs as they're developing in India, to me, is the most inspirational part in the whole world of what I'm seeing in the world of Clubfoot in lower and middle income and developing countries. And of course, the inclusion then of the orthotic care and how to get braces to the children, and this very creative and colorful use of the braces that you make in India. And I want to congratulate you all for having come as far as you have in this particular area. But then the next question is, well, okay, once we've got Clubfoot organized, which it really is now, how can we move Clubfoot into the more horizontal issue of all the structural birth defects, childhood diseases, deficiencies, and developmental delays that children suffer? It's not fair, actually, that a child with Clubfoot is treated extremely well and gets a perfect result, and a lot of these other conditions are then overlooked. So how can we become more comprehensive, and that's where the RBSK program that you have through the National Health Mission is, to me, inspiring. If this could happen in every country, I think the world of children's disorders would change dramatically. So, you know, the whole aspect of your district early intervention centers and the Anganwadi system that you have in India, and now adding the RBSK, very comprehensive program, including a Clubfoot as part of what they're looking for. And then the early intervention centers that you have throughout the state is really, their infrastructure is there now to actually treat every child with Clubfoot, every child with a birth defect, and every child that has a developmental delay and a disability. The examinations from head to foot of babies done in an organized way, with Clubfoot being part of it, is really the starting point of coming to grips with other structural birth defects in your state. And then the screening and referral card. In Uganda, we tried to include those in the vaccination card to try and pick up children with Clubfoot. But you see how comprehensive this is in picking up all these other issues. And I've highlighted the next step, the referral. So what we have in our Clubfoot systems now, and what you have in your state, is a very organized program of knowing how to identify and then refer babies with Clubfoot. I would say that that's not there for the majority of these other conditions out there. Clubfoot can lead the treatment program for Clubfoot can lead the way, I think, in being inspirational to other groups, other disorders, in treating other children. This is a photograph of me in Mumbai doing a home visit with one of the counselors. And this was such a wonderful experience to be actually in someone's home and to be with a counselor. And so the whole system that you have in India now of the ashas, and I understand there are now about 1 million ashas in all India, reaching the families where they're at in their homes. To me, this is another key that's going to make Clubfoot care in India and in the state of Kerala so effective. So the bottom line is that your state, Kerala, and India has the infrastructure, government support to implement horizontal clubfoot care, and are doing that in concert with NGO support and international support. And that you can then lead the world in horizontal and comprehensive clubfoot care. I believe you are already leading the world in your state and in other states in India, and we take inspiration from this. I can tell you that in Canada, we are not as organized as you are in having national approach to the treatment of clubfoot. It tends still to be province by province, institution by institution. And the other bottom line, that the Clubfoot program can now be championed as a template to tackle other structural birth defects. And this is the inspiration I would like to leave with you, to take this forward with all the infrastructure that you have. How can all the 4Ds of the RBSK take inspiration from the Clubfoot program and move forward? So thank you very much for letting me address you. And I take the position now that I see a few babies with a clubfoot. You are seeing vast numbers of them. You are the experts, and I'm actually learning from you. And thank you so much for having me as part of your faculty.
Thank you, sir. Can you hear me?
I can.
Yeah. I think personally I've been a great respecter of Canadian health system delivery. That's one thing, and it's a lovely suggestion that you made, that you could extend this and expand this clubfoot issue into a broad canvas of other defects also. So can I have some questions to you, please, with your permission?
Sure. Yes, very much so. I'm happy.
Yeah, happy to see you. Can we have the... Can we go back to this presentation?
Reads from here, you can read straight away.
Oh, you can give. Okay. Thank you. Yeah. It's full screen, no? It is full screen. Okay. So, sir, you seem to have a very happy and fruitful had a marriage between a highly specialized orthopedics work in Canada, what you call as a market economy, and a true NGO-like activity in Uganda. So how were you able to put both into the right perspective and juxtapose them into your activity?
Oh, what a question. And I would say, like Dr. Pirani, I was born in Africa and lived my early years in Africa. And at that time in the British colonial system, where I learned to play cricket, by the way, and I'm one of those few Canadians who are absolutely passionate about cricket, just like you are in India. So I think that having that Africa in my DNA was a huge factor. And then the rest is just serendipity, good luck, and the way things worked out. There I was working in Uganda, and Dr. Pirani visited me, and what a wonderful, perfect partnership that became, the two of us working there. And that happened by pure luck, I would say. Firstly, I've loved both doing pediatric orthopedics here in Canada and doing it overseas. But it's the aspect of equity and justice that's really at the root of things. Why should it be that children in marginalized situations should suffer so much when my children living in a wealthier country and with all the attributes we have life so easy, shall we say? This was a very big issue for me, the philosophy of that, and that's what took me to Uganda. And this working in lower income countries is to me the most productive and exciting and rewarding work I have ever done. The rewards are so great when you can make a difference in this kind of scale. So that's how it happened.
Wonderful. I think, so could you summarize your early experience with child disability in Uganda briefly?
Well, I think the experience there would be what you experience in many of the rural environments in India as well. And that is that children and families having no access to care. not knowing. We've already heard that how many families around the world believe that this is a curse and nothing could be done for it, and they're living out there in the villages without that knowledge and without anybody reaching them. And at the time I went to Uganda, it was just after the new government had come in after the calamity of the Idi Amin dictatorship and the Obote dictatorship. And the country was ruined, and it was considered among probably the lowest 5% in terms of development index on the planet. And so some of us went in there to help reconstruct the place. And it's moved forward dramatically in the interim. So everywhere you went, you were exposed to children who had treatable conditions that were now neglected, and resulting in permanent impairment and disability. And that was, so you had to start chipping away at this problem, and we chipped away at it in the Clubfoot area, amongst other. I went there actually treating a lot of polio, because vaccinations hadn't happened during that time, and we had lots of polio cases in the country, and many, many other neglected conditions. So that experience of trying to reach the poor with the most, to discover some of the very basic principles of orthopedics could make such a huge difference in children's lives was very impressive in those days.
Thank you, sir. And this is another question. What about the learning curve of Ponseti Mika? Because some of my friends were telling me that there may be some, what you call as a operator dependency also in this Ponseti method. So can there be an interdisciplinary dialogue between orthopedic surgeons, pediatricians, and pediatric surgeons so that we can make it less operator dependent? Do you actually think that Ponseti method is operator dependent also, or you feel that everybody can be trained?
Well, it is very specific. You must be trained in how to do it. I mean, it took us as orthopedic experts half a lifetime just to figure out how to move our finger 1 centimeter from the calcaneus to the talus. So it's very, very specific. It has to be taught very accurately. But can it be taught to non-specialists? Absolutely. And that's what's been shown, not just in Africa, but in India and many, many places, that this can be task shifted to non-experts if they simply do the technique right. They simply have to be shown where to put their fingers. And I think one of the really big problems we're seeing around the world is the idea that orthopedic surgeons should only be doing surgery and should not be doing all the other aspects of orthopedic care, including conservative care. And so this is part of orthopedic surgery. That's where it's always been throughout history. I don't know that there's a role for pediatric surgeons anymore, if you're referring to pediatric general surgeons or abdominal surgeons. It's really in the orthopedic domain. Pediatricians need to be involved with us, but I think the hands-on aspect of it, of actually knowing how a foot moves, that can definitely be outsourced to orthopedic officers, to orthopedic technologists, people who are good with their hands. If they've got proper training and proper supervision, they need to be supervised within the orthopedic domain. In the early years, I think it's gone now, but in the early years, those of us doing the Ponseti method had to try and convince our surgeon colleagues that they didn't have to operate. It took some time for that paradigm to shift, especially much more so actually in the developed world, where we really thought we were expert and knew what we were doing and that surgery was the way to go. It was a much more difficult effort for us to shift the paradigm in North America than it was in India or Africa, interestingly enough. But that battle has now been won, and anybody around the world who now believes that a primary surgical approach is necessary for clubfoot is simply out in left field, let's say.
Thank you, sir. I think that's wonderful. And I happened to read your article because we are all waiting with great it was a great way to talk to you, to speak to you. So we read your article on neglected Clubfoot. So do you think the substantial number of infants and the newborns do escape this safety net being picked up? And what will be the surgical result? Because if you are expected to go for some surgical intervention late in the natural history of a Clubfoot, what will be the result? Is it a good result or a satisfactory result? What would you grade this result as?
Well, to answer the first part of the question, yes, unfortunately, there are still large numbers of children that are escaping the safety net. As Roz Owen showed in that work, when we had introduced national programs, we're reaching about 25%. That means 75% are not getting early treatment. Now, I wrote that article many years ago. I was pressured into it because I had a huge experience in surgical treatment. And so something had to be written about this, and it seems like I've gained an international reputation in that, even though I do everything to avoid surgery. And what has been shown, really, from then and onwards, is that we can actually treat children who have delayed presentation, 4, 5, 6, sometimes 8, 9, 10-year-olds. We can still treat with the Ponseti method with very limited surgery. And and so surgery is still necessary, but we can do much more with it, much more finesse and with much limited surgery by implementing the Ponseti technique from the beginning. But it's necessary that surgeons have all the tricks up their sleeve, so to speak, when you have a very difficult case. And that's the role of that article in the neglected Clubfoot.
Thank you. So I think.
Well, I hope fewer and fewer children are needing the surgery.
Exactly.
But we have to get at them early.
Yeah, you have made it very clear, very crystal clear, and I think it's lovely. I think it has been an education for all of us. Thank you very much, sir. I will come back to you again if the time permits. Thank you very much.
Thank you.
Now, I was planning to ask one question to Dr. Shafiq Pirani, that is whether both of you have worked together in Africa. I think the answer already is given. So, good morning, Dr. Pirani.
Good morning to you all. Thank you.
Thank you for being here.
For inviting me to this very noble initiative and conference.
Yeah, I think we all listened to your talk in the afternoon. I think we are greatly impressed and enthused by this discussion. And here I want to ask you one tricky question which was asked to me by another pediatrician actually. Is this Ponseti method of Clubfoot management, which I think you have already answered this, but I think we want to be very clear on this. Is it a state-of-art management for Clubfoot for all, or is it particularly meant for what we call as, within inverted commas, developing countries? What do you call as low and middle income countries?
Yeah. The answer to that is very, very clear. It is the state of art. It doesn't matter where you are. Let me give you my reasons for saying that. First of all, it's instructive to understand that Dr. Ponseti actually described his article, his technique, first in 1963 with 12-year outcomes. And very little has changed in what Dr. Ponseti described in 1963 to what he described in his last publication in 2007. A few little points. And so it was really the orthopedic surgeons and others who didn't understand what Dr. Ponseti was trying to say, who prevented benefits of Ponseti method being applied to the population of Clubfoot worldwide for 50 years. What a tragedy. What Dr. Ponseti taught us is that a low load force applied gently over a period of time on growing tissues can change the shape of bones and change the alignment of bones. And we've shown that with our MRI studies. And the benefit over surgery is that surgery can only realign the bones with scar tissue. It cannot actually reshape the bones. And so the Ponseti method is the state of the art. And if we look at numbers, in the year 2000, from coding data from the United States, 90% of all children born with club feet had surgery. And that number went down to 10% or less a decade later. And so it's amazing to think that this technique, which was first published in 1963, took 40 years to take on in the surgical community, and then things changed almost overnight. The world of Clubfoot was turned upside down, and the responsibility for that really came from the parents, who, with the advent of the internet, got access to information which they didn't really have before. They got access to information and they demanded the treatment. And it was the surgeons who had to follow the parents. The surgeons who did not, the parents were told, if your surgeon doesn't do Ponseti, stand up and leave the office. Stand up and leave the office. So yes, it is the state of the art. And it's incredible to think that state-of-the-art treatment is being advocated in Kerala at this time for the entire population. It's not something that is emphasized that much in Canada.
Thank you, sir. You're both a pathfinder and an innovator. You have taught us how you can, what you call your own Pirani scale score helps to manage Clubfoot effectively. And I think this is partly answered in your talk, that is how to help orthopedicians to manage Clubfoot with your scale. I think it has been very well illustrated. So I may not go into this particular question because you have actually with pictures and the new algorithm, I think, which will be probably popular and effective in Kerala also. And this again I was planning to ask you, but I got my answer. Now I think both Dr. Penny and you are like Stanley and Davidson, who met. Is it at Victoria Falls they met? Huh? So I always, suddenly I think that Dr. Penny and Pirani are like, at least in Ponseti, like Stanley
yes, it wasn't Victoria Falls. It was close by, but not there. It was,
not in Victoria Falls.
It was on the journey.
Okay, so
I was the lost one, and he found me.
Yes.
Oh, it was not the other way around. Okay. So
yes, we had a nice we had a nice breakfast together.
So
that's how we met, over breakfast.
Penny was asked, Dr. Penny, I presume. Anyway,
that's right.
Another personal question I want to ask you is, have you met Ponseti in his lifetime? Can you describe him to us, his work?
Oh, yes, I have many times. I met him first in the year 2000. I had written to him in 1999 describing that I was going to go to Uganda and take his method to Uganda to teach the method in Uganda. And he was quite surprised because at that time there was only 3 other people in the United States that would be practicing his method. And all of a sudden there was this person out of the blue who wanted to take his method to Uganda. And so I had actually collaborated with him in writing the teaching manual. And in the year 2000, which is the second year I went to Uganda. There was an important meeting in pediatric orthopedics in Vancouver, my hometown, and he came to Vancouver to deliver a lecture, and he then asked me to participate in his lecture to show some of the studies I had done, the MRI studies, to show that his technique worked. And then the story is quite funny because he had come to Vancouver, and before the conference, he came to my house for breakfast. And we had a nice brunch together, and we talked about what we did in Uganda. And then I told him about my MRI studies that I was doing. And this is a man who's now in his 80s. And he thumped the breakfast table with his hand like this, making a big sound, and saying, "I need to see those slides now." Now. And I had to scramble around and find the slides, and I showed him the MRI slide or the studies that I had done to show the effectiveness of his method. And he pointed to that, and he said, "You see that thing there? That's what I've been telling everybody for 40 years. We've been telling everybody for 40 years how his theory was corrected the club feet, and at that moment you could see the result on the MRI, and that's what he asked me to do." And after that, I found him even though he was slightly abrupt at the brunch, he was actually a very gentle giant. And his theory of low load pressure applied over a long period of time to correct the club foot was actually exactly how he treated his his students. He didn't admonish them. He would apply gentle, low load pressure over a long period of time to change their behavior. And I found him a terrific, he was a mentor of mine, actually. I met him several times over the years at various conferences. And he really was a great influence, not just to my career, but also to my thinking as to how to think about orthopedic conditions. Great man.
Yeah, lucky you, sir. Now we come to Dr. Ahmed Hassan, he's the Director of Operations from USA. Is it good morning there? Is it the Eastern time or
it's a great honor and pleasure to be here with everyone. Thank you very much to the government of Kerala as well as CIIT and all the organizers of today's conference.
What would be the time, sir, right now, where you are? What would be, is it
right
morning?
Now it is 15 minutes to 9 o'clock in the morning.
Okay, sir, right. Thank you. See, sir, because both the great people we already spoke to were from Canada, you work in US where the healthcare dynamics are totally different from your northern neighbor, that is Canada, what we call as a medical care for profit or whatever in US. So how do you manage that situation especially with this program?
Absolutely. So I think it's very important to understand, obviously, that the United States is a capitalist society, and so obviously profits are of great importance. However, one dynamic that that many people have noticed actually over the last decade or two, I would say more so over the last decade, is a lot of the millennial generation, the younger generation, are very interested in a mission-oriented organizations, mission-oriented businesses, and so that's why you see the propping up of a lot of companies now who take on, for instance, Tom's, which is a shoe brand. They take on a humanitarian mission. For every shoe that is purchased, they donate a pair of shoes. And so, although the United States is a capitalist society and puts profits above all, I think there is a new wave of humanitarian minded individuals that is really driving a lot of the business economics. So I think that there exists a window of opportunity for this kind of initiative to be very popular. And I also think that there are many different avenues in the United States, be it government funded, the NIH has and other government bodies have funding opportunities, as well as other organizations can offer funding. And then just the general public also usually provides financial support for these initiatives as well. And we're a relatively new initiative. And so, so far we have found good success working with Dr. Santosh George, Dr. Matthew Varghese, and the rest of the team with CIIT.
Thank you, sir. And again, this is, I think, has been to some extent very clearly answered by Dr. Pirani, but still, do you feel strongly that the Ponseti method is like one size fits all, that is market economies, emerging economies, everywhere it is? I think you must be agreeing with.
Absolutely. I think I'm not able to provide as good of an answer as Dr. Pirani did. I think absolutely the non-operative approach makes the Ponseti method very scalable and accessible and applicable to all different market economies. I would say that the difficult aspect would be the compliance, making sure that parent and child are able to attend follow-up visits for an extended period of time. But I think by and far, of course, the Ponseti method would be the gold standard treatment.
And what's the mechanism of action? How does your Little Feet Club work with health providers in US in taking care of kids with Clubfoot?
Absolutely. So we work with so we have medical directors, and the medical director here in the United States and in Detroit is Dr. Walid Yassir. He's the chairman, or he's the chief of orthopedics at Children's Hospital in Michigan. And he serves as our medical director. He provides a lot of the train the trainers and does a lot of what Dr. Penny also was reviewing, continuing a lot of that work, training the trainers and providing some advanced clinical training for the Ponseti method. And it's our hope that we're able to continue that work in India as well. Another thing that we do is health data infrastructure. We make sure that all of the data that is collected, all of the different metrics that are analyzed for clubfoot treatment are done so with integrity, securely, and are done so kind of effectively as well. And then lastly, this is something that we're hoping to continue and really push forward is the clubfoot research and innovation. We have some exciting ideas moving forward at the current moment, and we're in talking with Dr. Santosh and Dr. Matthew Barkis as well, and trying to make those things happen.
Thank you, sir. And recently I think I just read that the ex-wife of Bezos, Mackenzie Scott, has become a huge philanthropist with a different approach. So do you have that what you call the fine fortune of having such a big philanthropist helping you in US?
We have had the good fortune of having other practitioners, physicians, organizations, and general public support. We have not had any famous or celebrity donors quite yet. Okay. I will say that we recently received our federal tax exemption or our federal nonprofit status approval this year. So it is one of our goals for the beginning of the calendar year to land one of those celebrity funders, hopefully.
Post-Biden, I suppose.
I'm sorry?
Post-Biden, I suppose, that the tax reduction and all. Is it Trump era or Biden era? Joe Biden.
Oh, it is Biden era, correct.
Okay. No, I was just... and now I think we will come back to India and Dr. Matthew. Being the chief of the Clubfoot of India initiative, do you think that many clinical stakeholders like pediatricians and surgeons are not fully aware of this particular work you are doing and the method we are practicing? So how do you like to manage? But today I think I was very happy because I was taking a rounds in newborn for a cardiology babies, and I asked the first year neonatology residents, how do you manage Clubfoot? All of a sudden, she never expected that question from me on Clubfoot. She said, yeah, it is by a particular method. So I asked her, what is that method? She said, to my great surprise and pleasure, she said, Ponseti method. I think that itself tells you that you have been successful. Okay, so please.
Thank you. Thank you so much for having me here for the round table. It's fascinating. You would expect specialization to help you with better management. It does. Once you know the diagnosis, specialization really helps the person get better management as they get more and more experience due to more and more details of it. So we tend to get into silos. So when we become a specialist pediatrician, we get into the silo of pediatrics. When you get to a specialist high-risk pregnancy obstetrician, we get into the silo of obstetricians. When you get into a pediatric orthopedic specialty, then we get into the silo of pediatric orthopedics. So the problem of specialization, subspecialization is creating silos, which do not see what is happening in the other silo. So what I see is the specialization in different areas, the intersectoral, interspeciality conversations are minimized. So therein you need an oversight. Oversight of somebody as sensitive as the secretary that we have here today, who sees, okay, this is pediatric orthopedics, you need to understand what are the problems that need to be taken care of, which needs other specialty oversight. So unless that moving out of the silo and seeing at the big picture is there, someone has to do that. And to expect that I'll do it from my busy practice, or he'll do it from his busy practice at the Child Development Center, or you'll do it from a pediatric orthopedic, it's unreasonable. We have to create a system. Unless there is a system, such interlinkages will not happen automatically. So while there may be individuals who are enthusiastic and do it, unless there is a system, this thing will not change. So the reason is we have to create a system for this. They are doing their jobs. They are hardworking people. But within that hard work that they do for caring, they need to know that this is what's
happening.
So unless that information is shared in a systemic way, sharing will not happen. Don't expect it to happen, it will not happen.
And this I think again fascinated me. That is, most of our faculty today are excellent orthopedicians, reconstructive surgeons. They are somewhere doing upper limb reconstruction, so hand reconstruction. So why did they embrace positive method, which could be sometimes called as a conservative? Because generally the feeling that anything aggressive is the modern therapy, and anything conservative, even in cardiology, conservative management means a little out of step with the. So how did they? Why do you think that they have embraced these people? And
I can tell you.
You in particular.
I can tell you why I started thinking. I was a prolific operator for posteromedial soft tissue release. Why? Because my supervisor, my teacher, was a Clubfoot person, and I ran the Clubfoot clinic with her, doing the kites method in the 80s, early 80s. In the early 80s, I was doing the kites method. And most of them needed surgery. And till I finished my residency, my pool officership, I was waiting for my appointment in the medical college, hoping to get in. When I joined this hospital, and some of these patients were at least 4 years old when I had joined the registrarship and then left. So one mother came to me with a child with the foot going back into a little grotesque type of a deformity. So I asked her, thinking that, somebody has done a bad surgery. I asked her, who's done the surgery? She said, you only did it, sir. And I thought I did a good job. And I thought my surgical skill was very good, and I'm a good surgeon, and that's why many surgery patients with CTV came to me. Then I realized I knew only the short-term results. 4 years down the line, I had not realized the result will be this. And that set me thinking. That was early 90s. So I started reading. And I started my Ponsity method, one of the earliest in my part of the country, by just reading. And I didn't know. And I was lucky to have met Dr. Shafiq Pirani, sheer serendipity, that I met him at a meeting in Gujarat, where he was there, and we went in a restaurant, not even in a medical college. We met in a restaurant over dinner. And he had come with another group, I had gone with a WHO group. And they had taken to an ethnic restaurant in Gujarat, Ahmedabad, and common friends, doctors, they introduced me to Dr. Shafiq, and Dr. Shafiq, we started talking. Then once he started talking and I told him I'm doing Ponsity, then the world opened.
Changed.
That changed. And it was 1998 when I had started Ponsity, but I was not doing tenotomy, I was doing tail lengthening, because I was scared of doing tenotomy. One of the reasons many centers have low tenotomy rate is because they feel tenotomy will fail, their long term may be there. I didn't do it till I had that problem which I shared in the morning, and then I was doing, and I learned from Dr. Pirani, and then Dr. Norgrove Penny came in, and it's been a total eye opener. It's a paradigm shift, and the paradigm shift had several key turning points.
And see, if what will be the Clubfoot burden? Because I think this morning the burden of Clubfoot in Kerala, 3 people offered 3 different values. Dr. Penny was, Shafiq Pirani was saying around 1400, and it was some ranging from 500 to 14, because you have this 5 lakh people, 500,000 people babies being born, and you have one person, conservative estimate that will be around 500. So is it actually 500 or more closer to 1,500?
Look,
Because it becomes a major factor because you have 40 centers in Kerala, 14 districts. So which means an average district probably will get around 3 centers for Ponseti. And that would cater to total of, the difference is if you cater to 500, this thing, which would be very comfortable. But if it is 1,500, it may be
Yeah, actually, herein lies the problem in the appearances of the data that we get from hospitals. Hospitals will always have a selection bias. So unless you do total population-wide study and then look at the data, you wouldn't know the true incidence.
prevalence.
And there have been very few population-wide studies on clubfoot, population-wise, total. One of the earliest was in UK in the Exeter County by Ruth Wine Davis. And she did a county-wide study on clubfoot, and she had the results are published. But the highest rate that came were from the Maoris, that is New Zealand island population, captive. They're not moving around. It's easy to track them, locate them, and find there the incidence was almost 6 to 8 per 1,000 population. That's huge. But the global statistics and the most recent community-wide study was from Sweden. And there also the figure is close to 1 or
per
so.
1,000.
So that seems to be the consensus in different small studies, no large population. But herein you have an opportunity. You have RBSK there, you have ASHA volunteers there, every birth is being tracked. Here is for,
the right place
you
to
be the leader in generating evidence on this. So you can tell the world this is a statewide, multiple ethnic
Dr. Babu George,
origin
you can take
population.
a hint from that, very subtle hint. Another thing, I think it's almost like congenital heart disease, almost universal in prevalence. So it must be like a congenital heart disease. And now we come to the sage looking. So, Santosh, I think I've heard of him before through my friend, one of our common friends. You are a very passionate, we can feel the passion in you, eradication of clubfoot by Ponseti method. What made you move towards this so-called some sort of a missionary zeal to be to help us, our children?
Yeah, as I said earlier, it was 2008 when I first even heard about clubfoot. And we didn't know. Actually, it's I would say that it's luck. And all these things fell in place. And it's a real kind of good thing that I met Dr. Matthew. Dr. Matthew joined this movement. And in fact, when I was initially working for Clubfoot, we didn't even have an organization. And we didn't know we are going to grow like this. So we didn't even have any kind of business plan, not even a clear vision. But we just started. But as years went, it was so exciting. Especially seeing the kind of result, the impact we are making. Right. That actually inspired. And also, I mean, what else you can expect in a lifetime? You know, in a country like India, if you are able to touch one problem, and in this 12 years take it to this level, and I mean, so everything pulled me, and then I just thought this is the best thing I can do.
Right.
So no
path.
intention, no plan, but it just came, and I can say that I just surrendered.
So it's a great path you took, the right path.
Yeah.
And another question, I think this is partly to Sir also. If we popularize Ponseti method in Kerala, where will the fund come from? Your organization, state government, philanthropists, or all of them? What is your thinking process on this?
See, the state government is already giving indirectly. See, the doctors are available, treatment materials are available, the clinics are there, the system to identify and refer are there. Our organization will continue to train the doctors. There are certain things that we have committed in the agreement. And obviously, as an NGO, we always depend on the funds that we receive from others, individuals, companies, large partners. I'd like to even acknowledge we have nearly 30 partners. So some of our partners are already participating in this program. Steps UK, for example, they are one of our latest partners. Very good support. So I know that somebody will come forward, even as we grow, to give us more. Right. So it is not just one organization, not just the state government, or just the support from the NGO or partners. So it's a kind of a real partnership and collaboration.
It's particularly, I think, strongly, I mean, of last one, because Dr. Babu George put me into this role because he thought being a pediatric cardiologist, I don't have any stakeholder in this, so I can be a neutral person, you know. So that is the reason why I put, maybe because of friendship also. Another point I found out that this is a state-of-art technique, which is a very cost benefit. It has a very cost benefit. That is the attraction of this particular method, I think, that should come. And this again, you have already answered. One thing I want to ask you is that, again, with Dr. Rajan is here. And do you know that Dr. Rajan is actually a medical person who has become a civil servant? We have one more doctor who is become a civil servant. Sri Ram is there. So this is a very interesting times in Kerala nowadays. So the point is, do you think this vaccinations, HIV, tuberculosis, etc., take away most of the resources that you would like to get from philanthropist organizations? Or do you think Clubfoot also will get a reasonable slice of?
Yeah, I think you didn't read the first thing. It's very interesting.
Yeah, but I thought maybe maybe it might not be politically correct. That's why I skipped that.
No, we only beg actually. We don't borrow and steal. So, yeah, definitely. Especially in the last 2 years, because of COVID, a lot of resources were directed to COVID, and that's naturally. Okay. Yeah, naturally. But okay. Compared to TB and HIV, we are a new cause. Yeah. So many of our potential partners have not even heard about Clubfoot. Exactly. So they don't immediately give, but it takes time. But
naturally, because people are more concerned about survival than morbidity. So naturally, it's a time that you have to change that. Now that we have surmounted many more mortalities, I think we should also concentrate on morbidity,
but
quality
when
of life.
They see that little investment and that greater impact they are making, so many people are actually coming forward to give. So that way it is really good.
So thank you, Babu. Sir, I think it's time. I think we have a little 10 minutes little late, but I think hopefully, I think we have all learned together, especially me. Thank you, sir. Thank you, Dr. Rajan, for putting me into this interesting but very exciting position.
I want to say one thing, that when we have signed agreement with all the 29 states.
Right, I know.
So I have met, I don't know how many IAS officers. So I always tell that whenever I go to a secretariat, I look for officers who have brain and heart. You know, see, they should have competence. You asked me that question, whether I know that he was. I didn't know that. I didn't know, but then after interacting,
you could feel
that. See, it's not only understanding. Unless they have that compassion, it doesn't work.
Actually, I had put one question like that. Do you find our chief administrator of health helpful or not?
Oh no.
But that is that goes without saying.
In his presence, I mean, I'm not just flattering. It's a fact that what I see in him is that competence, compassion, and commitment. See, whatever he speak, he did it. Otherwise, we wouldn't have been here. So that too, I think it's really encouraging working with officers like him.
Yeah. No, I'll just add on to that. In fact, I've already told him on his face. I have told him on his face. I'm not exaggerating. I've been to any number of meetings, internationally, nationally, WHO meetings and everything. What do I find? The bureaucrats come, give their speech, wait till coffee time and disappear. Here is Dr. Rajan sitting from morning right till the end. That shows commitment. Thank you. That's all that is required. If you are a committed person, things follow automatically. Thank you so much.
Sri Ram Boya. He's left. He's there. He is one of our best. He was my student. And one of my close friends, ex-chief secretary, was saying it's one of the bright future of Kerala civil service. Again, a little bit of flattery, it's okay. Accept. No, it is when it is true. So thank you. So all good things must come to an end. Thank you, Babu and Dr. Rajan. Sir, you can conclude.
Thank you, Dr. Zulfikar. In fact, that was wonderful. In fact, without you as a moderator, it would have been very difficult for us to conduct this session because all the stalwarts in Clubfoot and the Clubfoot managements, when they are present, it is a very difficult task. Distinguished guests, in fact, we are at the fag end of this session. One question, in fact, I was asking when I was talking to my dear friend Santosh, that why are we focusing at Clubfoot? And when I asked this question to myself, in fact, I was just thinking that if I am mother and if a child is born with some or the other congenital anomaly, and if it is correctable and if it is not done, not only that child, not only that family, but that mother will throughout the lifelong will never forget, thinking that there is something within me, and because of that perhaps my child is having this particular congenital anomaly. And perhaps mother will not speak that to her husband, to mother, father or anybody, but she will live with that throughout the life. And therefore, when we are doing any interventions which are correctable, I think we are not only helping that kid, we are not only helping that family, but we are helping mother and then thereby the society. So that is the way, in fact, if we look at what are the ways by which we can take healthcare to these needy people, in fact, it brings in tremendous transformation in the society. A simple non-invasive technique is making baby's disability completely free to lead normal life. That is only possible because of the experts like you who have been putting enormous, your own effort, not only in your sphere of activity, but to take that effort in nook and corner of the country, which is in the world, which is amazing. And that inspires us to take some of this program forward. We thank each and everybody who have come and joined this session, and throughout the morning they are with us. And we look forward to your continued association with Kerala Health in particular. We thank our knowledge partners, WHO, UNICEF, Cure India, CDC, and technology partner eHealth. My special thanks to Dr. Santosh and Babu George, because on every day, in fact, we were online working to make such a wonderful program. And we are very confident that students, in fact, they may not be present right at this point of time, but as it is and available on YouTube, in fact, few of the teachers are here. In fact, I would encourage them to ask a question regarding today's conference. They will start, looking at all the recordings, in fact, very sincerely. And that's the way I think we will be able to take the message to each and every our future generation doctors, so that they will understand what knowledge they are getting connected to the programs and what contribution they can make while going forward. It was indeed a very educative and informative sessions for all of us, and also all the listeners and also future listeners. We thank all our colleagues, my dear colleagues, in fact, Dr. Ratan, Dr. Raju, Dr. Ramla Bibi and others, and especially field functionaries, because I always feel that the grassroots, these are our foot soldiers who have taken this program to the nook and corner in the state and also in the country. Hats off to them. In fact, in spite of the COVID, that was our, Dr. Manoj has said, even during COVID time, in fact, they continued the Clubfoot clinic. That clearly indicates the commitment with which our field workers are working. And we thank them because of their contribution at the field level. We take some steps, we evolve ourselves and go forward. With everybody's involvement, in fact, we are committed, and we are committed to our Honorable Chief Minister and also Health Minister. And we are very confident that in coming years, definitely, the dream what our Honorable Chief Minister has stated in the morning, that none shall be disabled due to Clubfoot, that would definitely we all will be able to achieve in the state of Kerala, and I think over a period of time perhaps all over the world. Thank you very much for all of your contributions. Thank you. We will close the meeting here. Thank you very much.